لا ايه ايه لا هذه طال عمرك مهمه في يحبونها كثير الشغلات.
اغلب الموسيقى اثنين بالجو.
ايه القضاء
نتكلم مقطع كامل كده على بعض عشان بس ننتبه.
طيب
ماشي وداخله كده صوت مقطع كبير.
طيب
مين ده اللي يجيبوا لي قبل الموسيقى؟ وهم يرعوا انها اصلا ضد
ما كان لها داعي.
يعني البيت مع
يزارون يعيشون مرحبا
يعني مع الناس
لكم هذا يعني
يفتي هو افتى وقرر.
كيف اتكلم بس بنزل لان في مسجلين جدد ما ارسلنا لهم الرابط. ايه السلام عليكم. السلام عليكم. 1 2 3 تيست. 1 2 3 تيست. دكتور أحمد، صوت واضح؟
واضح، يكون معقول واضح.
خلاص. اي خلاص. خلاص.
تمام الله عليك.
لا لا تيسر. في ناس طبعا ترسل بالشات بس ما اقدر ارد عليها صراحه اللي بالشات.
الشباب بعد او انت في غيرك اللي يقدر يرد؟
فيه معي بس ما هم على الزوم، على اليوتيوب شانل يصورون اي اسئله.
معك من
في اثنين من اخويا من الكليه خلهم مشاركين.
حط اليوتيوب حقين ولا بس المحاضرين ما يعرفون، علمهم انه فيه اليوتيوب في 1500 عشان ينبسطون، يسوون بس الزوم بسيط. الزوم تراه مختص في اليوتيوب.
هذه السنه الجايه ان شاء الله يا دكتور، الحين عرفنا مويتهم، السنه الجايه معناته ان شاء الله
فيها بزنس
ان شاء الله. حتى ال50 هذه بس فتحة باب على قولتهم. الله يستر. هذا وقته داخل على
في الامارات جاني مع شركه امريكيه. زمان جاني قبل وقت كورونا، جاني لا والله جاني قبل 4 شهور 5 شهور. يبون مقر هنا وعندهم دورات وما يبون اسم للسعوديين، يبون بس انا جيت اعمل بدخل مع ديوان، بدخل مع اخبار، يسوون تريننج خاص، تدريب خاص بحيث انه يعني يصير كانه مجانا. عارف
اتيكيت ولا
ايوه صح. عند الشيوخ تبي كيس لجنه. فقلنا ما بعد استاجروا، بس لما كورونا وقفت كل شيء نسوي تدريب. لا تكون انت نيتك طيبه ترى تجيك من كل جهه، الناس تجيك. يعني الحين 3 دبلومات كلهم يبون يسجلون، واحدة عن الكربوهيدرات حافظة، واحدة اسمها بس مستر عندها عيادات نفسية تبغى دبلوم 4 شهور، واحدة ثالث مساعد طبيب. كلهم علمتهم، قلت له احنا الآن مركزنا وقف في مركز الآن هيئة ونشتغل فيه لحد ما يعاد، لأنه فيه موجود عندي أخطاء ما قبل المركز معه. هم عارفين هذا اللي بلغت علينا. هو كان اصلا في الميدان ماله ذاك، جاب لهم 50 وسجلوا ناس بدون ساعه بدون ما وجد عطى فلسطين اسمه ايهاب يشتغل عندها الوسخه دي، عطاها فلوس. يعني هو يشتغل معهم يعرفون في السوق، عارفين بعض، فقالوا حطوا العين. اكيد مقابل قوي ولا يعرف متى ولا متى على تعليق ايقافي المتى.
يا سبب الترخيص طويل ترى، ما ترجع أصلا.
ما ترجع خلاص بعد سنة ونص يمكن الترخيص حقه. هو مشكلة ما يجي حكم تجارة، ما يجي طبيب وكذا وكذا.
بس نصيحة لك يا
دكتور، هو فوضى. أنا أقول له يقول لا ما فيش، خلاص لا ما في. لا مع ناس أعرفهم مناديل الحياة خطأ
اللوائح واضحة. يسر
هو ممكن
هذا قبل هذا بيجتمع معي رئيس الجمعية. قبل مباشرة.
Societal.
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 Societal cost.
Longevity.
Longevity. Overall longevity.
Longevity.
Overall longevity or suicidal cost. Longevity or suicidal cost. Longevity. Longevity. Impact on overall longevity or suicidal cost. Of course, there are some dark gains here and there, but much of what improved health and longevity was outside of the traditional confines of surgery. Especially the latter half of the century, this field of surgery really started to make an impact. Advances in our ability to control physiology and advances in operative skills and techniques in the areas of cardiac, pulmonary, renal, orthopedic, and neurological surgery all led to dramatic changes to our ability to improve health and increase longevity. These advances accompanied their own technological growth, but also brought us an unparalleled increase in cost to society. It also led us to a new era in which the main question shifted, or should have shifted, from what can we do to what should we do. As the century came to a close, the advances in minimally invasive surgery brought even more focus to the question of capabilities and feasibility as opposed to necessity or prudence. From surgical standpoint, the 21st century has been largely marked by the advance of robotic surgery. Robotic surgery is probably better described as a computer-assisted operating. Robotic devices serves a computer interface between the operator and the instruments. In some cases, that allows for some surgeons who struggle with straight endoscopic operations to mitigate some technical challenges. In other cases, endoscopic operation to mitigate some technical challenges. In other cases, it allows endoscopic operations to be done that otherwise not be possible by other means. The use of robotic interface very much influences what we can do. However, there are some potential downsides to computer-assisted operating. Cost of equipment like purchase and service and operative time probably being chief among them at present. The counter-argument can be made that since the operative words in computer-assisted operating is computer, it is likely that the cost curve will deflect to some degree in a favorable manner over time. Perhaps operative efficiency will improve as well as the human parts of the patient develops. هلا.
سوالف او كلام او من جوال كل شخص يقدر يسوي.
Hello, everybody. Dr. Patel, I think you can unmute from your side. It was held by administrator.
Yes, good morning.
Good morning, Dr. Patel. How are you?
Good, good. How are you?
I'm fine.
Congratulations on a very nice meeting here.
I think all speakers can unmute themselves if they are willing to share. It is my pleasure, Dr. Patel, that we are on again. And of course, we have to cooperate, as you know, to make
Sure.
future events more fruitful.
Yes. Do we have a big audience today, or do we know how many people are going to watch?
Yeah, I think it is above 1,000, but most of them will be through the YouTube channel. It is lab, because I think we get afraid that to get the capacity more than we can, but we have a lot of audience, fortunately.
That's great. Yeah, and they'll have to enable screen share later so we can share our presentations.
Yeah, that's fine. So if you allow me, I'll start my introduction. It is maybe 5 or 4 minutes speech. It is about the robotic surgery in general. Then you can make your speech. Then afterwards, you make your lecture. Is this fine with you?
It's fine.
Yeah. Well, thank you very much, Dr. Patel. Thank you very much, Dr. Shigo and the others, dear Executive Director of SRS, dear speakers, dear participants, ladies and gentlemen. It is my honor to be part of this international symposium of robotic surgery updates in Riyadh, Saudi Arabia. As you know, throughout the history of surgery, we surgeons have had wrestled with law to incorporate new ideas and technology. As our understanding of the human condition has evolved, that task has become sometimes easier and sometimes less easy. For the first 6,000 years or so of recorded surgical history, everything we could do didn't really make that much of an impact of overall longevity or social cost. Of course, there were some large gains here and there, but much of what improved health and longevity was outside the traditional confines of surgery. During the 20th century, especially the later half of century, the discipline of surgery really started to make an impact on public health. Advances in our ability to control physiology and advances in operative skill and techniques in this area of cardiac, pulmonary, general, orthopedic, and neurological surgery, and led to a dramatic change in our abilities to improve health and increase longevity. From surgical standpoint, the 21st century has been largely marked by the advance of robotic surgery. Robotic surgery is probably the better described as a computer-assisted operating. Robotic devices serve as a computer interface between the operator and the instrument in some cases that allows for some surgeons who struggle with straight videoscopic operations to mitigate some technical challenges. In other cases, it allows videoscopic operation to be done that otherwise may not be possible to other means. The use of this robotic interface very much influences what we can do. So the robotic in general performs well in anatomically enclosed spaces, but its lack of hepatic feedback results in a well-known risk of tissue manipulation damage. The open and dynamic anatomical barriers of the head and neck could be more forgiving. Nevertheless, the system and its rigid instruments could benefit from the enhanced sensorial input and instrument adapted to the surgery type to refine the surgical capabilities and exposure. However, the most important barrier to wider adoption is the financial burden, not only of the machine, but also its maintenance and consumables, it is expected the increasing competition should contribute to the decreasing cost. I really thanks Dr. Patel and the other speakers for their support in this event, SRS members and all speakers. We here in Riyadh, Saudi Arabia, are very grateful for the contribution of other speakers from all over the world. Last but not least, I hope you find this event fruitful in your career. We will meet again next June 2022 for the second International Symposium of Robotic Surgery updates in Riyadh through a virtual meeting. Thank you very much, everybody, and we'll move to Dr. Patel. Thank you very much, Dr. Patel. Please proceed.
Good morning. Thank you, Dr. Alharbi. Congratulations on a great meeting. I know we've been communicating for the last few months about this, and it's nice that it's turned out so well. I am the executive director of the Society of Robotic Surgery, and so I'm here to represent SRS, and many of our board members and faculty are part of this meeting to support you. And I think the key is it's a multi-specialty robotic surgery meeting. And that's important because obviously that's the best way to implement this type of robotic system is in a multi-specialty manner. I've been now doing robotic surgery almost 20 years. However, I trained in laparoscopic and open surgery, and slowly over time, those things did not become necessary for me. I mainly specialize in robotic prostatectomy, and now close to almost 15,000 cases. And I would say that in the United States now for prostatectomy, this is clearly a standard of care. So what we're seeing now is the world in different areas of transition, going from open to laparoscopic and now to robotic. And it's, I think, very commonly practiced now here in the US. In Riyadh, I've actually operated there a few times robotically, and I've been there to visit the country quite a few times. I think robotics is being embraced very well there in Saudi Arabia, and you have some very skilled surgeons there from what I've seen. And so our goal as the SRS is to help you support this meeting and to grow robotics not only in Saudi Arabia, but throughout the Middle East as well. So we look forward to supporting you. Our plan is to have a in-person meeting, hopefully in July of 2022. So hopefully you will attend and join us. And it's a multi-specialty meeting focusing on robotics and also on all the new technologies. The last meeting we had was virtual, and we had over 22 different robotic companies present upcoming robots. So we do see there's a change occurring as newer machines are coming to the market. These conferences will be more and more important as we highlight the differences between the Da Vinci and the new platforms that will be coming. So I think not only are surgeons going to embrace robotics more, I think we'll also have more options for different types of robots, for different types of specialties. And I think that will only increase the adoption of robotic surgery. So without further ado, unless Dr. Alharbi has more questions, I can give my lecture. Dr. Alharbi. All right, if I can go ahead and if you enable screen sharing, I can pull up my presentation. Thank you. Okay, you should be able to see my screen now. Great. All right. So my lecture is on robotic radical prostatectomy, which is my specialty. As I said, I've been doing this almost 20 years now. And so we're getting close to 15,000 cases just for prostate cancer alone. And so I'll talk a little bit about our experience, and I think it will be generalized to most other specialties as well. So this is the question really that I have when I sit down to prepare our data is, how did we get to where we are? How did we assimilate the information? And what did we learn from that? I think the key was when we started our journey 20 years ago, we started with a database, and that database has been maintained through all these years, and the team has grown. And so our patients are followed for up to 10 years in terms of their outcomes. And I think this is very important. And I think anybody who's embarking upon a robotic career that hopefully will span many decades, we should start with a very strong data team and a good protocol. The first things we looked at, and this was back in the early 2000s, this is when robotic surgery was still being questioned about the efficacy, the safety, the viability, the outcomes. None of those things were known. And so the two things we focused on early were complications and the oncology. We knew that for any technology to survive, it had to be safe, and in terms of complications, and also oncologically, it had to also be safe in terms of not being a negative for the patient. So we've published along the way, and we saw that as our experience increased, our complications came down. The majority obviously were in the first 50 to 100 cases, but now we've, I think, stabilized. We've stabilized to the fact that usually the complication rate's less than 5% overall, and for anything major, it's less than 0.5%. And I think these things will stay stable. There are certain things that will always happen. Every now and again, you'll get an ileus, you'll get a lymphocele, you'll get a bleed post-operatively that you're not expecting. So certain things never disappear, but complications do go down, and robotic surgery showed that overall the rates were low compared to open and laparoscopic surgery. The other thing we looked at was margins. We wanted to make sure that oncologically we were doing a good operation, and we found that margins and PSA recurrence were no different than open surgery. And so these two things allowed us to basically say robotic surgery is safe oncologically and health-wise for the patient. And now let's look at all of the other outcomes and how do we improve. And for prostate cancer, those are mainly continence and sexual function. Those are the other two main outcomes we look at. So how did we get there? How did we adjust? And as you can see, this is over 15,000 cases. So obviously, we've made a lot of adjustments over the way, from a very primitive initial standard robotic system now to the Da Vinci Xi and even the single port. So we've gone through 5 different robotic systems. And obviously, as the technology has gotten better, we've adopted different approaches. So we always monitor our outcomes, and there are certain important techniques that we've adopted along the way, and I'll describe those. This is one of the Patrick Walsh diagrams here, and you can see here, this is how we see the prostate. It's obviously attached to the bladder, but the key is the neurovascular bundle at the base, and that leads to quality of life issues and outcomes. So as we look at prostate cancer surgery, the oncology is obviously paramount. However, just as important in many patients are the continence and sexual function issues. And therefore, I look at a prostatectomy as almost a neurosurgical operation where we're being very careful of the neurovascular anatomy as well as the actual anatomy of the prostate itself. So various injuries can lead to damages that can lead to delays in recovery of continence and sexual function. So over the last 20 years, we have focused on improving these outcomes. The advantage of the robot, obviously, is you have 3D 10x magnified vision, and you have an articulating wrist that allows you to dissect very precisely around these very delicate neurovascular structures. And so I think the advantages of the robot in prostatectomy are very clear. I think for us, it's clearly the standard of care. And for someone who did open and laparoscopic, I think there's no doubt of its benefit of the robot. We've published a lot of papers along the way. Majority of this stuff we still do today. How we spare the nerves is important. The key is not only preserving some of the nerve bundle, but to preserve all of it and to preserve it without significant traction or trauma, because obviously those would lead to delay recovery of sexual function and continence. When the prostate is removed, this is the kind of thing we like to see. We like to see the urethra up top there and the two neurovascular bundles. So nerve-sparing prostatectomy, I think, is what has made robotic surgery go above open and laparoscopic, because we're able to see the nerves and preserve them better than we would do in an open or laparoscopic manner. We do have two different approaches. We have the conventional approach, which we see here on the left, showing these train tracks like nerve bundles, and then a new approach, which we've been doing for the last few years on the right, where the actual fascia that lays on top of these nerves is preserved. So the nerves are actually buried behind the fascial layers and you don't even see them. And obviously that leads to even less trauma because those nerves are not even exposed. So we published our newer approach, modifying our apical dissection, preserving the lateral prostatic fascia, and we've showed that this improves outcomes. And so not only are we looking at the oncology, but we're also looking at the patient's quality of life, sexual function, continence. These are very, very important. And we've been working on that. So here's a video. You can see here, we're using the Da Vinci Xi, so we can go from 30 down to 30 up. So now we're under the prostate, looking up. That round structure in the top of the screen is the prostate. What we're seeing below the screen is the rectum. And we're using the robotic scissors to slowly peel the fascia off of the prostate. And this is, we're leaving the lateral prostatic fascia intact here. So as you can see, the visualization is very good. As long as you're careful, usually you can stay out of the blood vessels. And you can see here, the anatomy is quite pristine here. You can see the different fascial layers. You can see the neurovascular bundle behind that veil of tissue. And so this is a nerve-sparing prostatectomy that we're performing on a young patient who is potent and continent, and we need to get him cancer-free. But you can see here, a lot of this we can just kind of push down, peel the nerves away carefully. We don't have to use a bunch of cautery. We try and minimize our traction. These are the principles of neurosurgical operation like nerve-sparing prostatectomy. So you can see here, we're going to do the same on the other side. And then what we'll do is we'll go back to 30-degree down on the camera and we'll do the nerve sparing. So this is the view below, and I can switch over to the other side. So now this is the anterior view. We're now above the prostate looking down, and we're trying to connect the gap from the anterior to the posterior that we just saw. So that space between the prostate and the rectum is created from below. And what we've done is we've joined the two. So here we have the prostatic fascia, the endopelvic fascia off laterally here to the right, and we've actually secured the neurovascular bundle. We're also doing the same here now on the left, where we've gone to the left side, still looking anteriorly, and we're getting into these fascial layers. Key here is to prevent the bleeding and to get into the right spot, and therefore you can connect the anterior and the posterior and have a nice clean dissection without too much traction or trauma. And then we just go ahead and clip the pedicles. And so there you can see the clips are now being placed. We cut and clip our way down. The key is to preserve the whole neurovascular bundle and to place these clips to secure the vascular aspect of the pedicle. And you can see here these clips are being placed slowly. We're trying to obviously be athermal, and the reason is we don't want the heat transmission to damage the nerve. So as much of this is done with cold scissors and with clips. Once the prostate is removed, I'll show you a different version. The prostate is now out, and we can see here that on both sides, the nerve bundles are present. The nerves are actually behind the lateral prostatic fascia, and they're well preserved. So what we found was by Leaving the lateral prostatic fascia intact, these nerve bundles could be preserved better, earlier recovery of continence, earlier recovery of sexual function, and these are the best results that we've seen to date. So I think obviously there's a balance between preserving the nerves and making sure that the cancer has been removed. So not every patient obviously should have a full nerve sparing. If they have a lot of cancer with extension into the nerves, the cancer does need to be removed. What has changed over the last decade or two is the oncology of the tumor. And what we're finding is, since I arrived here till now, each year the cancers do get worse. We have more and more stage 3 and stage 4 tumors. And so we're having to do more radical dissections, having to take more lymph nodes. And this is because a delay in diagnosis, but also I think a change in the genetics of the tumor. So we are seeing an increase in the adverse tumor characteristics, more seminal vesicle invasion, more extracapsular extension, more lymphovascular invasion. I think most of us around the world are seeing an upgrading and upstaging of these tumors. Some of this may be related to the U.S. Preventative Task Force decision back in 2012 to question PSA screening, its utility and its use, where they actually started to say that maybe PSA screening should not be done. The feeling at the time was that maybe prostate cancer was not important and people didn't die of it. But I think over the last few years, we've seen that that was probably not an accurate assumption. Prostate cancer is the second leading cause of cancer death in males in the United States, and it's the number one diagnosis in males in the United States. And so based upon this questioning of PSA screening, I think less screening was done, and there's been a significant delay. And what we've seen is that since the task force decision, you can see our 5,000 cases before and 5,000 cases after the task force decision, the adverse pathology has increased significantly. And I could say clinically, we definitely see a lot more positive nodes, a lot more metastasis, and a lot more higher grade, higher stage, higher volume tumors than we were in the early parts of our experience. So high-risk disease is definitely going up. And therefore, obviously, if the cancers are larger, there's more extension, then obviously nerve sparing becomes a challenge because the nerves are intimately attached to the prostate. And if these tumors are escaping the capsule, then we also have to remove some of the nerves often on some of these high-risk patients, and that can affect their continence and potency. So then we had to figure out a new balance. How do you avoid positive margins? How do you avoid leaving cancer but still save nerves? And so we've gone to a full nerve sparing versus a graded partial nerve sparing. So not every patient needs a full nerve sparing or can have one, but you also don't have to remove all the nerves. And so we've had the ability to do quantified nerve sparing based upon the oncology of the tumor, based on the prediction of the amount of extracapsular extension. So I think we've gone from an all or nothing definitely to graded, and I think majority of patients these days have graded nerve sparing, not just full nerve sparing. And we came up with a paper that we wrote with the guys in Italy who looked at our data of over 12,000 lobes of prostate, and we came up with a predictive model that would predict the laterality and the specific site and the amount of extracapsular extension that we would expect on patients. So this is a preoperative algorithm that we can put in the biopsy data, the PSA, and it tells us which is the side most likely to have extension, the site of the extension, and the amount. And so we use this preoperative nomogram to grade our quantification of our nerve sparing. This is available online for free. You can see the website at the bottom, the prec.it. And I think this helps. This is the only nomogram that we know of out there that actually tells you the laterality and the amount of tumor that you can expect to have extension. And I think this helps. There are ways to try and grade this. I think if you're not experienced, it's hard to know a 1 or 2 millimeters here or there. And so we have found some landmarks that help preserve the nerves more fully, and you can follow these landmarks during surgery for your nerve sparing. There are some branches off the obturator artery that go to the prostate, and if you can identify these, you can use them to save the nerves. And as you can see here, this is a specimen where all the nerves were removed. The prostate's up there on the superior left aspect, but you can see that whole neurovascular tissue. The bundle is quite large. There's an anterior medial, a posterior medial, and a lateral artery. And so in a full nerve sparing, all those would be preserved, whereas in a wide resection, all of those would be removed. So you can use those vascular anatomical landmarks to adjust your nerve sparing. So this is a posterior view. There's the posterior medial artery. If you're medial to that, that's your first entry into a full nerve sparing. If you can see that and you preserve that, all the neurovascular tissue should be lateral to that vessel. And so you're getting close to doing a full nerve sparing at that time. What we found is if we preserve these arteries and we stay medial to them on the prostate side, you have a very good nerve spare. Whereas if you take those arteries and go lateral, you're losing probably at least 50% of your neurovascular bundle. And so you can use that to grade on different patients what type of operation to do. Here's the anterior view. Here's the anterior medial artery. Here we can see we're going lateral to that artery, leaving it on the prostate side. This is a young patient who has a high risk of extracapsular extension on the nomogram, and so we're doing a partial nerve preservation. And so what we found is that even though the oncology of the tumors are getting worse, the outcomes in terms of margins, PSA recurrence is staying stable because we've been able to adjust our operation to account for the increased likelihood of extracapsular extension in these patients. So this is a wider resection. It gives us a good 3 millimeters of clearance from the capsule. You can see it has some extracapsular extension there. And the advantage here is 85% of extracapsular extension in patients with prostate cancer is within 3 millimeters of the capsule. So 85% of these patients should be clear margins if you do it right. So overall, I think, prostatectomy is challenging because not only are you removing an organ with cancer, it's also something where the continence, the sexual function, everything is at risk. It's not just plucking it out. You can't just turn up the cautery and just burn it out. You'll have very poor outcomes. So it is a very delicate balance between the oncology and the quality of life in patients. Also, you have to know that it's not just the surgery that affects the outcomes, and that's what makes prostate cancer so challenging. There are other things, the age of the patient, the body habitus, the obesity levels, the anatomy, the patient's compliance to rehab with pelvic floor or penile rehabilitation. All these things affect the outcome. So the surgery is only one part of it, and I think that's important. Other things to notice, everyone's asking questions about the Da Vinci single port. It's available in the United States. We've had it probably about a year and a half now, and we've done over 100 cases with it. It's definitely a different learning curve. It's a different instrument. You only have one entry now into the abdomen, and so obviously it has its strengths in that there's less holes, but also limitations. In that there's less flexibility because of the fact there's no wrist. It has a shoulder and elbow, but no wrist. And so there are challenges with adoption, but I think it is something that is the next step. I think if you look 10 years from now, probably all robots are single port of some sort. But obviously the technology has to get to where it becomes standard. So majority of time we still use multi-port, but single port is an option. Here's a video, here's a side view, and this is how they look. You see you have a flexible camera, you have flexible instruments, we're doing a prostatectomy, and we're just looking at everything from the side here through an accessory port that we've put for the camera. Looks a little different than you would imagine. The advantage is, obviously we have a single hole. The disadvantage is obviously the instrument's also not as strong because now you have an elbow and a shoulder and these things that are holding. So this is single port. I'm sure you'll all get a chance to use it. I think it's there's a lot of optimism around single port, and it'll just take time. It'll evolve with the technology. We've published quite extensively on single port approaches and the modifications over the last few years, so these are available to you as you start your single port journey. I think overall, I've done almost 15,000 cases now of robotic prostatectomy, and I still sit down every day and say, okay, let's see how this one's going to go. I could say 90% of the surgery is probably predictable for me now, but that 10% is always dependent upon the patient anatomy and what's happened before. So there are no easy cases. The easy cases are hard and the hard cases are easy. So there's a continued learning curve. We're still learning, we're still changing. Um, I think the oncology is getting more difficult because the cancers are worse. And so we're having to modify approaches, and obviously that can affect the outcome. So that's important, is we definitely need to find these patients earlier and stratify the ones that do benefit from surgery and get them taken care of. So I think, a lot of our videos, we have a YouTube site, the Robotic Surgery Academy. So you can go on YouTube and search, and there's hundreds of videos of this operation and different kinds of operations on the Masters of Surgery website. So hopefully you can visit that. And so once again, I want to thank our colleagues in Riyadh. Dr. Alharbi has done a great job. And the SRS is pleased to support you, and hopefully you'll join us for our meeting next year. Thank you.
Thank you very much, Dr. Patel. It is an honor to be working together. And thank you very much. I know you have very limited time, but is there any question from audience, please, for Dr. Patel? So I would like really to know your opinion. You said that the single port robotics is coming in 10 years. It's going to overwhelm the robotics in general. Do you think it will be for all specialties, or you mean it's in urology robotic surgery, Dr. Patel?
No, I think these robots evolve naturally. We have a lot of new systems coming, and ultimately these systems will get smaller. We'll need less access. I think once the single port robot has the same flexibility, the same strength as a multi-port, then it makes sense to fully shift. Right now, the single port is for certain selected candidates, more optimal anatomy. The more difficult cases are still easier with the multi-port because the instrument has obviously more angles. It has a wrist, and it's a stronger platform. But if you look in the future, as technology evolves, I think all of these will start to become smaller robots and need less access. I think we're going there. I think the next frontier really is probably imaging. We need intraoperative advanced imaging. I know how to take a prostate out. I know the anatomy. What I want to see is how close is that tumor to the capsule? How close is it to the nerves in real time? That's what would actually improve my outcomes. So actually, I think the next frontier is not just the robot getting better, but the accessory things we do with the robot, especially imaging. That's what needs to improve.
Thank you very much. One more question, Dr. Patel. As you know, the main symposium, actually the main mission of this symposium is to study what are the future potentials of research to support cost reduction in general, not in urology, in general robotic surgery. So what do you think about the vision or the future research projects about cost reduction? What I can see that the robotics, it's also following almost the whole science progression for improvement without much really consideration for the cost. But do you think the cost consideration, is it quite valid in future research and international and in US, of course?
Yeah, the cost issue is definitely valid. It is expensive, and the costs do need to come down. it needs to be available to more people around the world. It shouldn't be just for the wealthier hospitals and the wealthier patients. I think with competition, that's the only thing that's going to drive costs down. Obviously, the robot has evolved over all these years and more cases are done, but the costs haven't come down. They've probably gone up. And so I think the only thing that will drive costs down is probably competition within the market, with other robotic systems coming on board. I think that's probably going to be the key.
I see. Thank you very much, Dr. Patel.
All right.
I know that you are busy, you have a clinic right now, but I cannot find the questions. Maybe people are going to send the questions later on, but I'll let you know if there is any serious question or something that deserves your attention.
All right. Thank you so much. Good luck.
Thank you very much. Have a good day.
Thank you. Bye.
Now we will move to Dr. Shaggy. One. Dr. Shigyu, are you with me? Dr. Hori?
Hello, good evening, Professor Alharbi.
Thank you very much. I'll just give a brief introduction for you, Dr. Hori. Is that fine?
Please.
Just 1 minute.
Yes, please.
I really thank Dr. Hori from Japan. Dr. Hori is the professor and the chairman, Department of Urology on John Tyndall University. And Dr. Hori is a surgeon scientist of the University Graduate School of Medicine. He is graduated in Tokyo in 1985. He did his research and clinical fellowship at the UT Southwestern Medical Center at Dallas, studying renal physiology and clinical transplant. In 2003, he became the chairman of the Department of Urology of Tokyo University. He initiated the first men's health clinic in Japan. And in 2012, he was appointed as the chairman of the Department of Urology, John Tyndall University. He is currently the president of Japanese Society of Men's Health and the president of Asian Pacific Prostate Society. He published more than 200 peer-reviewed papers. Dr. Hori, the stage is yours. You are welcome, and thank you very much for your contribution. Go ahead, please.
Thank you very much, Professor Alharbi, and good evening, or good morning, good afternoon, everybody, my friends, and also robotic surgeon. And it's certainly my honor, great honor and privilege to have this opportunity, and I truly appreciate Professor Alharbi for providing me this opportunity. And I find that probably I'm the only guy in East Asian robotic surgeon. So can I share my slide, please?
Yes, you can from your
Okay,
desktop.
thank you.
Welcome.
Oops. So my topic today is 3D simulation of robotic partial nephrectomy. And I don't have any conflict of interest of disclosures. So briefly, let me introduce myself for my institution, Juntendo. My hospital and university is the oldest school of Western medicine, which was founded in 1838. So almost the same era as universities in the United States, such as New York University or Johns Hopkins or Europe Humboldt University in Berlin. And actually that currently our university hospital group is the largest university hospital group in Japan. We have total six hospital inside Tokyo and also in the vicinity of Tokyo metropolitan area. Our total bed is more than 3,000. And this is the main hospital building, which is located in the center of Tokyo. So when you have, after the COVID, when you have chance to visit Japan or Asia, please please visit us, and you're always welcome. So actually, for the renal surgery, now the fashion is a partial nephrectomy. Evidently, if you compare the radical nephrectomy and the partial nephrectomy, actually the partial nephrectomy, the overall survival is lower than radical nephrectomy because the progression to chronic kidney disease is less frequent in partial than radical nephrectomy. And actually in Japan, 2015, robotic partial nephrectomy is now covered by national health insurance. And from that moment, we have a lot of, we have more opportunity to do partial nephrectomy. The question is how to prevent chronic kidney disease postoperatively. And you need to decrease the ischemic damage during the operation. And for that purpose, you need to shorten warm ischemic time, which is early amp clamping. And also you can try or you can seek segmental clamping of renal arteries. And for this purpose, that I will introduce you surgical simulation and also intraoperative navigation in robotic surgery. For the innovation of surgery, I think there are three important components. Number one is the preciseness or precision of surgery. And number two is less invasiveness of your surgery, such as robotic surgery, and also efficient training of the surgeons for the next generation. So I'm going to talk about precision surgery or precision urology using robotic surgery. For introducing precision surgery, the most important tool is multi-detector CT scan. So this multi-CT CT scan has tremendous amount of data, which is not imaging, but each image can be analyzed as a collection of many dots. And by using a tremendous number of data, we collaborated with Fujifilm company, which is Japanese camera company. And they have the technique of recognizing human face. And by combining the technique and also the data from a multi-detector CT scan, we can construct a 3D imaging of the component of kidneys. So we co-developed the software called Vincent in the Fujifilm. And actually, this is a segmented 3D imaging of renal anatomical structures constructed from the CT scan. individual slices of CT scan is 0.5 millimeters. And by this construction, you can tell the artery is a red one, and vein, and the urinary tract, linear parenchyma, and the tumors. And this is actually the cyst in the kidney. So this is a conventional imaging. It is a 2D imaging. So we urologists can tell where the tumor located. But if you show this imaging to your patient, it's very hard for a patient to recognize what's going on in your kidney. But by constructing a 3D segmental model, and also you can make a construct your real kidney model by 3D printers. So we usually make explanation of the operation to the patient, show the real size of the kidney and tumors, and explain the surgery and explain how we excise the tumors like this. And also on this 3D imaging, we can do what we call virtual partial nephrectomy. We can plan it, we can simulate how to make the surgical margin of the tumors like this. So this is a planned virtual partial nephrectomy, and this is a real partial nephrectomy specimen which I operated. So it's quite similar compared this virtual imaging and also real operative specimen. And also at the same time, by using this software, you can measure what's the what artery will be irrigating, perfused to the tumors, and what portion will be occupied or perfused by individual branch of your arteries. So this is by mathematical calculations, which is called Voronoi analysis. But by using this method, for example, that when you do a portion nephrectomy, this portion is not clamped. This portion is clamped. So you can tell this portion, you see some bleeding here, but this portion, this is a vascular, you can find a vascular plane. And we publish a paper, the functional outcome prediction before and after the operation. And actually that the predicted postoperative EGFR is quite much with the real postoperative EGFR like this. And also this is a part of a simulation, but also you can incorporate this imaging into the robotic monitors using the function of tile flow. So of course it's probably if you can overlay this imaging to the real monitor imaging, it's wonderful, but still it's in progress. But compared the tumors and the vasculatures and also urinary tract, you can, even the novice surgeon, you can do the surgery more safely. So this is intraoperative navigation technique. For the partial nephrectomy, there's a situation for challenging cases, such as larger tumors, endophytic tumors, hydra tumors, or cystic tumors, multiple tumors, or solitary tumors on high-stage chronic kidney disease. So let me show you some two difficult cases of in a video clip.
Dr. Hori, we cannot
Yes.
hear you.
Can you hear this?
Oh, yes, yes. Go ahead.
Can you hear the narration of the video?
No, the video, it's only slides. There is no audio.
Oh, okay, sorry about that. Yes. Okay, so now we put the bulldogs on the linear artery, and we do the resection of the tumors. And actually, the tumor thrombus is extending to the linear vein, and you can see this yellowish tumors here. And Hemalock is used to cut the renal vein like this, so you can see the tumor thrombus here. And we reject the tumors, and we do a linolaphy. So it's a linear sutures, yeah. And operation time was 140 minutes, but ischemic time was 19 minutes. So we successfully preserved the patient EGFR. So patient didn't go to dialysis in this case. The next case is complete endophytic tumors. Yeah. Because the tumor is completely endophytic, it's very hard to identify tumors by conventional surgeries. And we try to do a partial nephrectomy with selective clamping. So this is the case for selective clamping. So this is a preoperative vagal nephrectomy planning. And there's a several branches, linear artery branches here. And we can estimate to resect these tumors. It may be okay to just clamping a third branch of linear artery. And this area, only this area will go to ischemic. So this is probably the 14% of total kidney. So potential area is 14%. Compared if you do the total clamping, it's 100%. So first, we just expose using ultrasonograph. So the tumor is completely endophytic. So, but we make the margin of the excision. Its margin is marked using ultrasonography. And also we prepare for selective clamping. So actually dissect the renal hilum. So this is the third branch of linear artery. So we found this branch of the artery and clamp only this branch artery. So ischemic area identified is in yellow. So only this portion is in ischemic condition. So now we cut the tumors. So this is a minimal, renal parenchymal loss. So this is a lensography by Velox and Vicryl. So in this case, surgery time was 121 minutes. Ischemic time was 18 minutes. So actually that EGFR change was not significant and the margin was negative. So in our experience, mean tumor size was 3.0 centimeters, and the preoperative creatinine was 0.8, and EGFR 76.6. And operative time, median operative time was 183 minutes, but ischemic time was 19 minutes. And estimated blood loss was 50 cc. And of course, in the learning curve that we have one case which over 500 cc of blood loss. And actually, margin positivity was only one case out of 278, so it's 0.4%. So this is a learning curve for the tumor size. We started for the very small tumors, but now the size is getting larger and larger. However, the ischemic time was getting decreased, and the median time was 19 minutes. But now most of the case, our ischemic time is between 10 and 15 minutes. And the linear function change, still with a little bit of a decrease in EGFR, but I think it's almost not significant for the postoperative. So there's a little risk for going to chronic kidney disease. So this is my last slide. And for the precision surgery, 3D segmentation and the simulation and surgical navigation introduced in this presentation will enhance surgical precision, safety, and better communication with patients. So thank you very much, Dr. Alharbi, for providing me this opportunity. And thank you very much for listening to this lecture.
Well, Dr. Hori, thank you very much. And it is really nice to have this presentation, especially the 3D simulation. I think it's possible to be practical for all specialties, not urology. Am I right?
Mm. I'm a urologist, yeah.
Yeah, no, I mean, this 3D simulation can be utilized for all specialties.
Exactly. Any organs.
Because I'm a colorectal surgeon, this of course will help surgeons to simulate the tumor for the patient. He would be able to understand what are the expected complications. So how do you think other specialty would be able to progress or to upgrade this 3D simulation to their specialties? Is there any special sector or facility that concerned of this, or it is public for everybody?
Yes, you don't need any special devices for doing this, but the CT scan slices is what I'm doing now is a 0.5 millimeter. So it's very thin slice to collect a large amount of data to make a reconstruction, 3D reconstruction. And also software is available. So if you can do this thin slice CT scan, you can make a 3D construction, and also you can introduce the imaging of 3D construction into the robotic monitors in an intuitive SI or XI.
But I think the CT scan now are able to do this issue, especially the coloring type, which is make it more isolated. I think they can do it, isn't it?
Yes, exactly.
What about hospitals that they have old version of CT? Can they adopt this through some integration to overcome this problem?
I think so. I'm not sure that all company can do this, but I think most of the CT scan, most of the companies, I think can adapt to this technology.
I see. So it is very, very good tool actually to make a preoperative planning for, of course, the robotic surgeon, the supporting team of the surgeons, maybe for training, of course. I think it's very, very good too.
Thank you very much.
Yeah, thank you very much, Dr. Hori.
Okay, thank you.
I will meet again, maybe in a different time. Thank you very much.
Yes, thank you. Bye-bye.
Have a good night.
You too. Bye-bye.
Bye.
You.
We'll move now to the second speaker. Who is Dr. Jeffrey Scott Magginson. Dr. Scott Magginson is Dr. Scott Magginson is the Chief Medical Officer of Advent Health Nicholson Center, and he is the Medical Director, Head and Neck Surgeon, and Advent Health Center Institute, and University of South Florida College of Medicine Global Robotics Institute. Dr. Magginson, he is a well-known figure working as in a medical West Surgery Center in Bessemer, Alabama. He got his university degree of Texas Medical School, Houston, Texas. So we will start the presentation of Dr. Magginson. Thank you very much for your contribution, Dr. Magginson.
Robotic surgery has been around now almost 20 years. I've had the privilege of being in. These are
لا دقيقة بس. لا دقيقة يا راجل. هذيك عليك يا راجل.
خلاص بس انا مش بالضبط عشان اقدر اشرح.
طيب، دقيقة. عندك مكان ولا دقيقة؟
لا لا
work your way to Apollo. Applications are significant. And we felt
يا راجل. يقول يجي رايد نفسه يجي خليه يجيب. أنا رايد هو يفتح رايد. رايد ثانية دقيقة. خزنه عندي وبعدين سجل باسم ثاني. الفيديو تغير ونحطه باسم واحد ثاني.
بس
إيه، لو فتحته له.
الان لقيتها.
إيه لقيته قاعد أنزله من اللينك. 3 دقائق.
which is required in the United States for certification of laparoscopic surgery. And the development of this fundamentals of robotic surgery was a joint educational program from the United States Department of Defense grant and an unrestricted educational grant for intuitive surgery. It's a multi-specialty, proficiency-based curriculum of basic technical skills to train and assess surgeons to safely and efficiently perform robotic surgery. These were the leaders of fundamentals of robotic surgery. I'll point out from the Nicholson Center, represented by Roger Smith, who's a computer scientist, and also represented by Dr. Nicole Bell, who's a urologist here at our institution. But these are all the organizations represented. There were over 100 surgeons participating in the development of this curriculum. And even our American Academy of Otolaryngology Head and Neck Surgery was represented. Greg Weinstein and I both participated in the development of the curriculum. What we created was a series of exercises that were performed by the surgeons using a robot, and then taking those exercises and creating a number so that we could set a benchmark for proficiency. And using the Dreyfus and Dreyfus model, proficiency is defined as proficiency is designed as the mean of the experts. So the score of the experts take the mean, and that's proficiency. Competency is 1 standard deviation below proficiency, and expert is 1 standard deviation above master at 2 standard deviations. So developing the curriculum, we wanted to prove the effectiveness of the FRS curriculum using the skill sets that were developed. This is one of the simulator models that was developed for the fundamentals of robotic surgery. There has approximately 8 different exercises on this dome that can be performed. And they're performed by the surgeons as this surgeon is performing here, where he's performing a simple suturing, going along and running a suture and tying the knots at the beginning and the end. How do we score this? Well, if we take a robotic assessment tool called GEARS, GEARS stands for Global Evaluation Assessment of Robotic Skills. This was developed by urologists in 2012. If we take this assessment tool, which has 6 domains, you can watch the surgeon perform the exercise and give the surgeon a numeric score. In this case, the perfect score would be 30. And then taking those scores by the experts, again, taking the mean, we know that what is the proficiency level expected for that operation, that exercise. There's another way to score surgeons, and that is using computer simulation. And here is a machine developed by Mimic, which is in the United States. They're a surgical simulation company. And you go through these exercises. There are many different exercises. And again, by training surgeons, you measure them towards the expert, what's toward the expert. And in the computer simulation, there are several scores that can be provided based on several metrics. We have quality and proficiency metrics, time to complete exercise, economy of motion, master workspace. And we have risk and safety metrics, instrument collisions, excessive force, instruments out of use, all things that have to do with risk and safety. You can take those scores and get us overall some score. And we know that score is a pass or fail based on, again, what did the experts score in these exercises. Here at the Nicholson Center, we have a multi-day basic robotic surgery course. We take novice surgeons in any specialty and we train them through several days, and we can score them on the beginning of their training week, the middle of their training week, and also at the end. And we can show that with this systematic training using fundamentals of robotic surgery, we're able to decrease the number of fails that we see in a specific exercise. We can also decrease the number of incompletes. That is, the surgeon may not necessarily fail, but the surgeon doesn't complete the task for the exercise in the allotted amount of time. And so with training, we can show that we can decrease these 2 points. Using the Mimic scores, in this example of a single class of 10 surgeons who took the week-long course, you can see in each individual surgeon along the front part of this bell-shaped curve. And with training, we can take their initial performance as it relates to quality and efficiency surgeons on their early side of the bell-shaped curve, and we can move them into the median and upper quartiles for training. Why is it important to be in the upper quartile? Here's a great paper published by Richard Gotti, who's a urologist at the University of Michigan. And they took insurance data from the state of Michigan, and they looked at the differences between the lowest quartile of surgeons performing prostatectomies and the highest quartile of surgeons. And I'll point out, especially at the bottom, the readmission rate in the highest quartile of surgeons was significantly less than that seen in those surgeons in the lower quartile. How is this information helpful? Well, we can identify surgeons who are in the lower quartile, take them to a training program or identify exercises where they're deficient and train them up to put them up into the higher quartile. So now let's go directly to some lessons of mastering dissection of algebra the last several years using the robot. We'll first discuss value. In setting up the robot, discussing the three primary operations that we do with transoral surgery. We have the limited pharyngiectomy or vaginal tonsillectomy. We have the resection of the tongue base, and we also have the supraclavicular care. It's important to understand that the robot is not out the same way for each of these three operations. Let me demonstrate. These two pictures are paired. These two pictures are paired, and these two pictures are paired. And what I'm demonstrating here are the three different ways that we've done each of the operations. So the more proximal in the urodigestive tract, so in the oral areas for limited pharyngiectomy, the instruments are actually spread relatively far apart. Where if you're thinking about doing the operation without a robot, just a headline, the surgeon is looking straight down and the arms are spread out nice and wide, working at the front. And so that's what I have set up here. We have a 0-degree camera facing directly down, and the instruments of grasping and energy devices are spread far apart, heading towards working space. Now, what happens if we move more distal in the urodigestive tract or at the basic top? What happens if the surgeon again doesn't have a lot? The surgeon leans back, look into the mouth, and brings his arms closer together to reach that tongue base. Well, here, we don't have to lean back. Use the camera. We can switch this camera to a 30-degree camera facing up and maintain the vertical orientation of the camera. That's helpful because then we don't compete for the space between the instruments. And then you see the instruments are now more side or horizontal. This is our arm, and they're closer together. We can bring our elbows closer together so we can get to that tongue base. Now let's go even more distal. Working space here becomes more narrow. We're in an inverted problem, a cone-shaped working space. We're getting now down to the supraclavicular pharynx. We keep our 30-degree upward facing camera or vertical oriented. And we move our instruments now very close together, just as if we're working down in the larynx. Our arms will be very close together as we're getting to that distal work. So in this case, the robotic arm becomes very flat. There is no space between the arms for a camera. It doesn't matter if the camera for vertical orientation. And these instruments can come close together. Now, the next step I'm going to show is instrument movement. What I want you to keep in mind is there is a lot of space for these bedside instruments to be moving. Not in a supraclavicular pharyngiectomy. There is very little room. There could be a high number of collisions between these instruments because they're so close together. How do we decrease our collisions in our instruments that is close? It has to do with the instrument. And so in this video, the top row represents all of the same instruments, and the bottom row represents all of the same. And I differentiated these two different types of styles of dissection by this top row is considered laparoscopic technique dissection, and the bottom row is considered robotic technique of dissection. So in the laparoscopic dissection, the whole instrument arm is moving, and you see how much this instrument moves at the patient's side. is this done from the master console? Well, specifically, the shaft of the instrument, or the black part of the instrument, is represented by our forearm, so that this can be our wrist and our elbow. If that forearm is moving, the whole shaft of the instrument is moving. That is true for the SI, it's true for the XI, it's also true for the single board. But if I rest my forearm on the armrest of the console and I don't move my forearm and I only move my hand from the wrist to the finger, which is only moving the tip of the instrument, you notice that the instrument at the bedside is very still, very little movement, limited fluidity. The tip of the instrument can still run the outline of what I want to cut. And notice how I do that in my hand. I don't have my fingers inside of that Velcro steroid. I have my fingers on the outside, but I can roll my fingers over the master control and control the master control without having to turn my wrists to my forearm. Fishing handling. In these three videos, we see progression of the dissection of the right hand. As I begin my incision, I'm using my narrow dissector, not as a grafting instrument, but as a retracting. I've got the tines without the narrow boat, and I'm placing the knife break on the incision without retracting. As I get visible in my dissection, there's more tissue, and more super that's in the way. And I will crawl with my instruments on top of each other. You see here, I'm placing my narrow, I then place the monopolar, and I crawl. After the fact, but now I do it before, and that decreases the risk of catastrophic bleeding if you do the neck dissection ligation before the tool. Margin management. This is what I call real-time margin management. Since we're doing on-block resection, when I see that I begin to hit the tumor, I can back up and take the margin and keep that tissue attached. That at the end, I can show the pathology I truly have that margin. And finally, structural point. It's especially important in home-based surgery compared to supervised manipulation. After you size this tube, put the specimen back in its anatomical orientation so that when you grab an edge, you know what edge you're grabbing. Even at the superior edge, you know what edge you're grabbing. Again, I want to thank Professor Joy and Bill for this opportunity. I would like to offer the Dixon Center for Training Courses in the future. Please contact us at nicholsoncenter.com/calendar for any information regarding training courses in the Dixon. In 2021, we see these courses have travel is allowed. We welcome any trainees who would like to come to the Dixon Center for both a basic robotic surgery training program that is specialty non-specific, or a tours basic course, or even for those surgeons who are performing tours but like an advanced course. We have these dates available. Again, nicholsoncenter.com/calendar. For those surgeons who may be interested in transoral robotic surgery for obstructive sleep apnea, we have a virtual course coming up in February. We hope that next fall we'll have a hands-on dissection course here in Orlando. But if you're interested, these are the dates for our virtual course led by Claudia Chichi, Paul Becky, and Julia Crawford and myself. Thank you for your attention. For those interested in contacting me, here's my email address, scott.magnuson@edmonton.com.
Thank you very much, Dr. Scott. It is really good to see you again. And because of short of time, sorry for the audio. I don't know really what is the main issue. We are trying to solve this technical problem. But anyhow, we will move to the next presenter. The next presenter is Dr. Muhammad Shamim Khan, is a professor of urology and surgical education at King's College and consultant urological surgeon at Gayes and Street Thompson Hospital, London. He is one of the pioneers of the robotic surgery in UK, and he has an international recognition for making a major contribution in robotic cystectomy. Please, from the audience, if the audio is still bad, please let me know. Professor Khan served as a director of BA US Office of Education for 3 years and a member of a specialist advisory committee in urology for 5 years. He has been a co-chair of the UK National Simulation Program in Urology, a member of Joint Committee of Higher Surgical Training and joint led surgical BSc King's College London. Professor Khan has over than 5,000 publications to his name, edited 2 books, contributed to 10 books chapters, and delivered more than 150 plenary lectures at the international meetings. He was awarded Order of British Empire in 2007 for humanitarian work. Thank you very much, Dr. Shamim Khan. We will start your presentation soon.
Hamid,
Yes?
can you hear me?
Yes, this is Dr. Khan.
Yeah.
Yeah, thank you very much. Please start
Okay.
your presentation.
Okay, thank you very much. So, firstly, thank you so much for kindly inviting me. It's really an honor to speak to our brothers in Saudi Arabia. So, the topic you have given me is robot-assisted radical cystectomy in 2021. Will it survive the tide of the emerging evidence? So, firstly, I have no conflicts of interest to declare. And coming to the actual topic, I will cover 4 main areas. Number 1, as to why we are looking for an alternative approach to open radical cystectomy, which is considered as the current gold standard. What are the benefits and the drawbacks of minimally invasive cystectomy? The evidence for and against the robotic cystectomy and what impact it has had so far on the clinical practice. And lastly, what is the way forward to improve things in the management of bladder cancer? So firstly, addressing the question of open radical cystectomy, we all know that what are the problems with the open radical operation, particularly radical cystectomy, is bleeding, requiring transfusions, more pain. Many patients develop ileus and as a result stay in the hospitals much longer, and wound complications are not insignificant. Minimally invasive cystectomy, whether we do it laparoscopic or robotic, reduces the blood loss and therefore minimizes the need for any transfusions. I don't remember transfusing any patient over the last 5 years for the sake of blood loss.
Can you share, Dr. Shamim, can you share your screen, because we don't see.
Is it?
Yeah, we don't see your presentation actually.
Okay, that's very sound, but
share your screen.
Okay. Can you see it or no?
Not yet.
Okay. What about now?
Not yet.
Okay. Let me come out of it and then redo it. Can you see it now at all?
I can hear your voice, but there is no slides. I cannot see your.
Okay.
So I think it's a sharing issue. Yes, it is working now. Yes.
Okay.
Yeah.
So talking about minimally invasive radical cystectomy, whether we do it laparoscopic or robotic, there are 4 key advantages, which is the minimal blood loss. We hardly ever transfuse any patients now. less morbid incisions with better cosmesis, and rarely we get any wound infections. Hospital stay is 4 or 5 days shorter, and the recovery is faster. Traditional laparoscopy, however, those who do laparoscopy, they would agree with me, it is just like performing the surgery at the end of a long stick. Because the 2D vision, poor ergonomics, the counterintuitive movements of instruments, and the learning curve is much longer than robotics. And almost 90% of those surgeons who practice traditional laparoscopy in their career end up in having occupational injuries. So we have robotics now. This is the technology which makes minimally invasive surgery much less taxing on the surgeon, achieves similar objectives, although at a much higher cost. But may I remind you that we did not start doing robotic surgery because there was evidence to show that it is cost effective or it produces better oncological or functional outcomes. Rather than that, it was the promotion by the industry, the hospitals, patients, and the surgeons. What was there for these stakeholders in this technology? Intuitive and hospitals obviously wanted to make money. The patients want minimal incisions, no transfusions, less risk of infections, and shorter stay. Whereas the surgeons were much more convinced that this is the best technology to use for minimally invasive surgery because it's a 3D vision, 3 arms instead of 2, intuitive motion of instruments, and wrist articulation. All these features of robotics makes the minimally invasive surgery much less taxing and easier compared to standard laparoscopy. However, after practicing robotic surgery for 20 years, people are now realizing that it is not just the technology, but the surgeons are equally important, if not more important, because if you give a fool a tool, he will still be a fool. So therefore, the healthcare providers have started questioning the wisdom of spending more money on the healthcare and particularly on robotic technology if it is no better than the traditional laparoscopy or open surgery. And the procedure which has been criticized most is the robotic assisted radical cystectomy. And as a consequence, most of the surgeons who practice robotic surgery in bladder cancer has been motivated to do randomized controlled trials compared to prostatectomy and partial nephrectomy. So if you compare the 3 main urological procedures, then there are only 1 decent trial published in radical prostatectomy which showed no difference. Partial nephrectomy, there have been no trials, and radical cystectomy has been 6 trials. Of the 6, 5 trials have already been published in high impact urology journals and 1 in Lancet journal as well. So I will take you briefly through these various trials. So the first trial was published in 2010, which included only 41 patients, 21 were robotic, 20 open. The primary endpoint was lymph node yield with a non-inferiority margin of 4 lymph nodes. What was the outcome? Robotic approach was the non-inferior to the open approach, and robotic approach did better than open approach in several perioperative parameters. The trial was underpowered and conducted in a single center. The next trial, 3 years later, again a small trial, 47 patients, but data only on 40 patients were published in Journal of Urology. What it showed, the higher blood loss in open operations and a better lymph node yield in the robotic operations. So the trial was underpowered and single center. And these patients were randomized to 60 to robotic, 58 to open. And the oncological outcome was the main endpoint. The follow-up was some patients up to 5 years. And what it showed, no difference in recurrence or cancer-specific survival or overall survival. However, the trial was not powered to prove differences in cancer recurrence, survival outcomes, or patterns of recurrence. We published our randomized trial from our center in 2015. This was comparison of open, robotic, and laparoscopic radical cystectomy, and the endpoint was the complication rate. What we found that at 30 days, the complications were significantly higher in open radical cystectomy compared to laparoscopic, but at 90 days, there was no difference between open, laparoscopic, or robotic arms. It was underpowered and single-center trial. The last trial, which you will see mentioned a lot in meetings, is what this trial published in Lancet Journal from United States in 2018. So what this trial was about, progression-free survival at 2 years, and also few secondary endpoints, which were mainly perioperative parameters. What it showed that there was more blood loss in the open operations intraoperatively. More patients in the open arm required blood transfusions intraoperatively and also postoperatively. And quite a few of those who had open operations had a longer length of stay in the hospitals. The only difference which was positive for the open cystectomy was that there was shorter operating time. This trial, although published in Lancet Journal, also had multiple flaws. The surgeons and the patients could not be blinded. Only academic centers participated in the trial because obviously they are doing large volumes. Multiple surgeons were involved. The extent of lymph nodes and the choice of neoadjuvant chemo was left at the physician's discretion. Pathological review was not centralized but standardized, and all the diversions were extracorporeal. That means through a mini laparotomy. But in conclusion, this trial also did not show that the robotic cystectomy was inferior to open radical cystectomy. The trials which have been conducted so far have been criticized by the fact that they have been small trials, underpowered. They did not describe the clinical pathways. They did not apply enhanced recovery path protocols, and diversions were all extracorporeal. So therefore, what would be an ideal trial for radical cystectomy? Something which compares the totally intracorporeal operation with the open radical cystectomy, similar urinary diversions, and applying enhanced recovery pathway. Now, such a trial has just been completed in the United Kingdom. Nearly 350 patients have been recruited into the trial. It's called IRAC trial. We are analyzing the results, 3 major centers, 1 from Sheffield and 2 from London. There are a few other smaller centers. The primary objective of this trial was that 90 days alive and out of the hospital, and recovery and complications. We hope that this trial will be published by the end of this year. So the trials which have been conducted so far, none of them showed that the robotic cystectomy was inferior to open radical cystectomy. The problem of the randomized controlled trials in surgery, which are considered as a gold standard in evidence-based medicine, is that the surgical procedures are much more complex than drug interventions because the surgical procedures vary from one patient to the other. Surgeon performance can vary, the surgical team, and pre and post-operative care. But if you see the trend of the robotic cystectomy adoption world over, almost 50%, 55% of their cystectomies are performed with the robotic assistance. More so in the United States, almost 77%, and about 50% in Europe. In my center, we started the program 17 years ago, and about 80% to 90% of the radical cystectomies are done with the robotic assistance. So the question arises as to why, if there is no evidence of superiority of robotic assisted cystectomy over open, then why are we doing this operation at a higher cost? So devil is always in the detail. There are differences, but they are not major differences. So the differences are in incisions, blood loss and transfusions, post-operative analgesia, recovery of bowel function, hospital stay, post-op recovery, and wound complications. I can assure you that all these domains, robotic cystectomy does better than the open cystectomy. We have published our results in multiple journals. As far as the oncological outcomes are concerned, they are equivalent. My friend and brother, Khurshid Guru, established the International Robotic Cystectomy Consortium many years ago, and they have also published the 10-year outcomes showing that oncological outcomes of open and robotic cystectomy are equivalent. So what I can assure you after having done this procedure for 17 years, that there is less blood loss, shorter scars, shorter length of stay, and complications are either equivalent or less. Higher cost, no question, and the longer operating time, but I can assure you, if you do many procedures, like you were listening to Vip Patel, is a robotic operation. I don't think many open surgeons can match him in terms of operating time. So more you do, you get better at it, and equivalent oncological outcomes. Robotic cystectomy has definitely gone through the phases of evolution of feasibility, intracorporeal reconstructions, and prospective randomized trials. The reason I think most of us are disappointed with the robotic technology because our expectations were unrealistic. What we expected, the robotic technology will make a huge difference, but actually the difference is not that significant. It's about incisions, transfusions, infections, and length of stay. What I can assure you that the patients who benefit most from the robotics approach are females, because you can take the specimen out through the vagina. Obese patients, patients who are undergoing surgery for palliation with cutaneous ureterostomies, those with a poor performance status, and those who had previous radiation therapy. They are the best candidates to benefit from robotic cystectomy. There is no doubt that robotic surgery is more expensive. So as Patel alluded to earlier, the way forward would be more competition in the market, which will drive the cost of robotic surgery down. At the moment, definitely robotic surgery is more expensive than open and laparoscopic surgery. However, in spite of the cost, world over, robotic surgery is being adopted in all surgical specialties. because of its advantages. And likewise, in United Kingdom, which is considered as much more conservative society, 92% of the prostatectomies, 82% of partial nephrectomies, 73% of nephrectomies, and 50% of cystectomies in urology are done with robotic assistant. Likewise, if you look at the other specialties, for example, gynecology, colorectal, and thoracic, this approach is increasing. For example, in uterine cancer, about 40%, in colon cancer, 60%, and in lobectomy, almost 60% are done robotic assistance. So you may say that, okay, there is no evidence, but there's a fashion in operations as there is in sleeves and skirts, but that is how it is going. If the robotic surgery becomes cheaper, I can assure you people will start the questioning, the argument that why robotic to why not robotic. And you may agree or may not with me, but most of the evolution in surgery has resulted from technological evolution. But one thing we must accept and realize that although technology is evolved and has evolved, but biology does prevail. So if we have to make a progress in the management of bladder cancer or any other cancers, it is not just by making the technology superior, but by working together, whether we are clinical oncologists, medical oncologists, scientists, open surgeons, laparoscopic or robotic surgeons. It has to be multimodal and multidisciplinary approach to management of cancers. We are very fortunate to have a very big team of different disciplines providing bladder cancer service in our center in Guy's and St. Thomas's Hospital. The message to my younger colleagues in Saudi Arabia or around the world is that robotic surgery is here to stay, irrespective of the trials, not showing statistical differences. There are clinical differences. Robotic assisted radical cystectomy has emerged as a minimally invasive alternative to open radical cystectomy with the goal of reducing the procedure-related morbidity. As the technology stands now, it is not going to affect the biology of the tumor. And lastly, not the least, while the debate continues, I would urge the young generation not to be among those who regret not having learned the robotic surgery. So I will encourage all the younger surgeons to get onto the training programs of robotic surgery, whatever your specialty may be. I appreciate your very kind attention and thank you very much for inviting me.
Thank you very much, Dr. Shamim Khan. It is really a pleasure to have you in this meeting. And I find that everybody is pushing forward for this robotic despite the concerns about of the cost and other issues. But I think you agree that with time that the cost issue will vanish over time once there is more competition, as most of the surgeons says. And we will find ourselves end of the road that robotics is becoming like the laparoscopy, similar to the last decade. Is that true, Dr. Khan?
I think that is very true. In UK, there is another company called Cambridge Medical Robotics, CMR. So they have launched a machine which is, of course, as good as the Da Vinci, because Da Vinci has been in the market more than 2.5 decades. So they're not able to compete with them. But we were very optimistic that the Medtronics and the Google and other big companies, Johnson & Johnson, will launch their machines very soon. And that will drive the prices of the technology down. I have no doubt in 5 to 10 years' time, the traditional laparoscopy will be obsolete. Open surgery will be very, very restricted. And the other day we were having a debate about training in open surgery, that how we are going to train the coming generation in open operation for a small number of patients who may still need open operation. So the question is going to change from, for example, minimally invasive will be the way forward. And the only challenge will be how we are going to manage the open operations. And you might be seeing that in colorectal as well. So at the moment, we have 7 robots in our trust. 6 are Da Vinci and 1 is from CMR robot, which they have loaned to us to just do a trial on the new machine. But I have no doubt that the future is robotics, and that is how surgery will be done.
Thank you very much, Dr. Shamim. I'll be in touch with you soon. You presented very valid data. It is too much interesting, actually. So thank you very much.
Thank you so much. Thank you so much. Very, very kind of you for inviting me. Thank you so much.
Thank you very much. Thank you.
Bye then.
We will move now to Dr. I think it is to Dr. Mohammed Mutahar Ahmed.
Yes, I'm here. Can you hear me?
Yes, but yeah, we have some. I'm trying to open my laptop to introduce you, give the short bio, but my laptop is freezed. So I'm sorry, but please present yourself. I'm sorry for that.
Yeah, that's okay. You don't need introduction. my name in Arabic, Mutahar, tell you all about it. It's Africa. So there you go. Am I correct?
Yes, you are right. I have your short bio, but my laptop is freezing. It can.
All right, no problem. I do all my surgery robotically. Once in a while, we do open, including cystectomies, but my focus is mainly on efficiency, how to make this robotic surgery efficiency, and I'll share a few of my thoughts on that. And
Thank you very much. Go ahead.
All right. So, this is an old picture. Everybody knows this picture. This is from Brady Institute in 1922. First prostatectomy is being done. And of course, we have moved to robotics. And 1999, we had the first generation of the Da Vinci robot. And it was originally made for thoracic surgeon. I think everybody knows that. But urology got a hold of it and they just took it off. And in 2014, we have the XI, which I think is the best model so far of their generation. And of course, in 2019, we have the SP, which is a single port, making the minimal surgery even more minimal invasive of doing it. And those who still debate robot versus open surgery, both get you there. And obviously, horse carriage got us to where we wanted to go back in 100 years ago, but it got you slower. It got you not in a finesse, not in a stylistic fashion. And a 4-wheel sports car will get you to the same location in a much better and much comfort level. And talking about open surgery versus robotic versus laparoscopic, just from the surgeon point of view, in terms of ergomatic, I mean, we can last a lot longer now that we're doing robotic surgery. Can you imagine doing a laparoscopic, your shoulder takes a toll. Doing an open surgery, your neck takes a toll. But robotic surgery definitely makes the surgeon lives and surgeon less visit to the orthopedic surgeon. So that's another key important to remember, I think, aside from all the results and everything that we always talk about, which may be equivocal or same, but for the surgeon, it's a lot easier. And for the patient, obviously, you could see these horrible, nasty incisions, and we're down to this. This is a patient who got actually a radical cystectomy with a neobladder, and you could see the incision is not comparable. And obviously, this will give you less pain, as Dr. Shamim Khan mentioned earlier. So in my experience, personal experience, and as a group, we had done over 10,000 robotic cases. But personally, since 2003, I have done close to 5,000 cases. And you could see all various types, prostate, nephrectomy, nephro-U, adrenal, a lot of reconstructive surgery, as well as cystectomy. And of course, with the advent of the SP, the single port, since 2019, I have done about 300 of these cases. And of course, the pattern has changed, because back in 2005, I would say about 80% of our surgery was prostate robotic surgery. But right now, since 2014, and especially in 19, you could see that the prostate volume or the total amount of case of total volume is actually about 1/3. So kidney has taken off, cystectomy has taken off, and other reconstructive surgery has taken off. So for us, the prostate is becoming less of the total volume because we are able to, progress this robotic surgery into other areas of urologic surgery. And so what's the secret? I'm actually not a full-time academic. I have half of my is academic and half of is my private practice. So what is the secret to develop, 300-400 cases a year? One way I look at it is, and of course, the number of cases, as you mentioned before, the more you do, the better you get. So how do you get that number of patients under your belt? So one is you got to have a good referral. You got to be respectful and courteous to the other urologists, because the best referral is from the other urologists. They diagnose a disease, they give it to you because they're not doing robotic or they're not that expert. So you got to be courteous at them, allow them to have a say in the decision process, and make them feel that they're a great clinician and you are a sort of like a technician, that they're not doing that part, so you're just helping them out with that. And of course, keep the complication low and patient satisfaction high, and words from the patient's mouth goes a longer way. That's actually the best referral for any of us in the long run. And the other thing you got to focus on, foundation of practice. Yeah, you could do things fast, but that's not everything. The quality is important, efficiency is important, and cost effectiveness is important. So what is the quality? Adopting minimal invasive surgery, using a better stapler, using a better instrument. And efficiency is, of course, if you have those better instrument, better quality equipment, you can decrease the docking time. The old robot, the first generation, was a headache to dock. The XI makes the life a lot simpler in terms of docking. Decrease the patient position time. You can do this case supine as opposed to doing it in lithotomy. Our cystectomy prostate, we don't do them anymore in lithotomy. We do them in supine. It's a lot more comfortable for the patient. Enabling to do multiple, a procedure, let's say nephro-U, instead of redocking it twice with the XI, you could do it in the same docking. So that saves time. Engage the residents, fellows more efficiently because the robot is easier to use. And of course, cost effectiveness. You got to find a way to combine, use the instrument for multi-purpose. So you're not using 5 instruments, you could cut it down to 4. That's a direct saving of $250. So these are the things you should start thinking about and build that into your foundation as you do more robotic cases. And so why does this matter? Efficiency, this whole thing, right now you're going to hear a different hospital system talks about quadruple aim. So what are the better outcome, lower cost, improved clinician experience? Like we're able to do something with less pain, less headache, and we're able to last longer time. And of course, improve patient experience. All these things adds to this efficiency. And so what is efficiency? How do you define that? Is it number of cases you do per day? Of course, because the hospital is always looking for able to get more cases out from a single robot, from a single day. So that's important. Wheels out, wheels in. You could do the case really fast, but if the patient doesn't move in quickly, if the patient doesn't go out of the room quickly, that's not going to be helpful either. And of course, skin closure. A lot of time, we tend to think that, okay, this can be done by a resident or by a nurse practitioner. But sometimes you really need to set how it should be done in a proper fashion, because the surgery can be 1 hour, but skin closure ends up taking 15 minutes. So that's not efficiency. So that's something you have to think about as well. And anesthesia time. So that is very important, because a lot of time we tell anesthesia, put the patient to sleep and keep them under, don't make them move, because I'm doing the robotic surgery. Patient cannot move. But that is not an ideal, because once you're done with the case, anesthesia will take at least 30-40 minutes to wake up the patient, because they have them under so deep sleep. So you have to remind them, look, we're finishing the case. So about 20-15 minutes before the case, you let them know that you're going to be finished soon, so they can also manage and wake up the patient in an in-time fashion. So all these things are important, and that will help you become efficient. So what are some of the intra-op robotic efficiency, especially with the XI, that new 2014 model? So slight variation, when you put the port, slight variation does not matter. It is very forgiving. So that is important. Patient positioning, you could do supine position, as I mentioned before, the prostate, the cystectomy, the sacrocolpopexy, all these surgeries, we used to put them in lithotomy, we could put them in a supine. And I'm not going to talk about the single port, but with the single port robot, you don't even have to put them in a deep Tunnelberg position. So these are some of the modifications that can be made with the robot, especially the newer generation. And the docking, learn all the steps. Just because you are not going to dock the robot, but know all the steps. So that can help to train the nurses, the residents better, because you know all the steps. So learn the robot, learn all the function of the robot, and that will help it to become efficient. And also, one thing is, learn console efficiency, learn the anatomy. Don't be afraid to try new things. I always hear the surgeon says, I always do the same thing, and I always do the same way. But that's not how we actually learn things. You always, once you get comfortable, you try to see if you can make something better. So you have to try different ways. And different ways may be a better way, not just the way that you feel comfortable with. So that is the important point to remember. And here, I'm just going to compare, there's a slide comparing the XI versus the SI, which is the older model. You could see the docking time, it really saves time. So if you're doing an LAR, the docking time is a lot less with the XI model than with the SI model. Same thing with lobectomy, which is a lung surgery. Same thing with partial nephrectomy. So it does, this new XI, which is not anymore new, it does help with those efficiency. So the docking time, my personal time, you will see, I'm going to show you a quick video. It's about 6 to 8 minutes from the incision to the robot being docked. And you could do it efficiently once you get good at it and once you have an organized fashion. And one important point is, once you go in with the first port, if you see an adhesions, don't use electricity. A lot of these adhesions, soft adhesions, they can be just taken down with a cold energy, cold cut scissor, or just by pulling on the adhesions. Because avoiding the complication, especially at the beginning of the case, even if it is minor or major, will save you a lot of time. So try to avoid having any complication as you start the case. So I'm going to show you a quick video. Hopefully it works. Okay, can you see the video?
Yes, we do.
Okay, so I'm going to make it forward, go a little bit. So this is a partial nephrectomy. Here we are thinking about where to place the port. So if the patient is, everybody has a different way of placing different location. But generally, if the patient is larger, we go more lateral with these ports. So we're going to use 5 incisions because one will be an assistant port and the other will be all working port. And with the XI model, you could change the camera around, but I don't usually do that. We'll put the camera right here. And we go with varus. Now, again, you start to develop that feeling. When you are inside the abdomen, the varus is moving freely. It's not about a lot of time, number of clicks. Sometimes you cut through the fascia, you're not going to hear the first click. But it's once you put it in, the freeness of the needle moving in and out. And once we have some insufflation, we'll go ahead and put the other port. And then you'll see that there is a way of putting, you do 2 movement or 3 movement, not just constant push, because the constant push doesn't allow you to feel as you're going through the tissue. You just push constantly, the next thing you know, you're in the aorta or you're in some sort of bowel, you made an injury. If you go slowly and push and then pull back, push, pull back, that gives you a little better feeling of as you're going into the abdomen. So here we're putting the camera port, then we'll insert the camera. I just want to show you that the whole video here is about 3 minutes and 50 seconds. And so we'll have the robot in by that, within that 4 minutes of time. And here I'm actually working with the resident, telling them what to do. And he will put the camera in. So that will allow me to see the rest of the port as I'm putting it in. That's my assistant. So here we're already inside. We're going to show with the camera and the rest of the port under direct vision. So here we have the 5th port in. And then we're going to bring the robot and dock it. And the one thing is, with the XI, there is something called targeting. That targeting is a mystery. A lot of people sit down in the robot, then they will do the targeting. But you could do that targeting as you tag the robot, because there is a laser pointer that allows you to make the estimate where the organ is that you're going to operate and how the robot should be aligned. And I'll show you briefly where that laser pointer is. There you go. That's the laser pointer. So you can see that I'm making that laser parallel, the cross parallel to the organ that I'm going to operate. So the kidney is here. Sorry. So the kidney is here, and the laser pointing at that direction, and this is the alignment on this direction, and that is your alignment. You don't need to go inside the robot, spend another minute trying to align the robot. So, all right. So this was a quick, basic docking that can take you no more than 5 to 8 minutes. I mean, in this video we did it in 4 minutes. So, how to improve console efficiency? So advanced instrument is very important, right? Reducing number of instrument and tips for assistant and nurses, anticipate issues. So if you think you're going to do let's say a difficult radical nephrectomy or a partial nephrectomy, and you may get into the renal vein or get into the IVC, get a 3-0 proline or 4-0 proline vascular suture ready. You don't have to open it, but have it in the room. So if you get into that complication, the equipment is there. They don't have to run around and find an instrument or give it to you. So anticipate the move. That makes the things very easier in a difficult time. So another thing that I want to tell you, and I'm going to go over on how to use a single instrument for multiple purpose. One instrument that I find, and Dr. Alharbi, you'll find that very important because you do a lot of colon surgery and a lot of bowel surgery. That stapler, and I have this slide just for you. It's a sure form stapler. I don't know you are aware of it. The XI has a robotic stapler, and it's a very, very dynamic stapler. It does this, it controls it automatically, it does the stapling. It will measure out the thickness of the bowel. It does everything for you once you lock it in place. And then once you set to fire, you could actually get up from the robot and take a little break, and it will automatically fire for you. And I'm going to show you a quick video of that. And this is all the different angulation comparing with the other robotic stapler or laparoscopic stapler. I don't think there is any stapler that comes close to this stapler. And the cost is also less. If you use this stapler properly, you can reduce the cost. We have done studies in our hospital on that. You could see the difference in cost. But I just want to show you this of this stapling device. So here you go. So again, notice that I'm using a lot of stay sutures. This is a post-cystectomy. I'm doing an ileal conduit. Here, so I'm using a lot of stay sutures. This is very important. You have to set yourself up because it's not an open. So here's another stay sutures. And you see that I'm not going to use any special equipment, but use the bipolar to go through the mesentery. So that will save you a stapling cost. You're using the bipolar, and you could easily now. Here is a sure form stapler at work. And you could see how ergonomic this thing is. It angled almost 90 degrees. And so it allows you to staple at ease and very easily. That's one equipment that XI, I think, made a tremendous improvement on, the robotic stapler of the XI, the sure form. And it has 45 and 60. So for bowel, if you got fire 160, that's good enough because you don't need more than that for the anastomosis. And then you could do end-to-end cutoff. So here again, I have stay sutures, which is very important. And then you'll see one thing I'm doing, another stay sutures to hold the bowel all the way to the pelvis. And so that gives you that alignment. So you could bring in the robotic stapler or even a handheld laparoscopic stapler. And it allows you to align it easily. So you see what my fourth arm doing right here? That is making it easy for the stapling to take place and alignment to align it correctly. So usually my conduit doesn't take more than 45 minutes. I used to do this thing with a laparoscopic stapler, but this I find a lot easier. And you take away a lot of the assistant job, so it makes it more standardized. So here I'm going to do just fire off the end, and you'll see we aligning it with the robotic instrument, perfectly aligned, and bring that sure from stapler. And it's a 60, so it's pretty long enough. And in one firing, So at most of these small bowel, ileal conduit, or a neobladder, all I need is a 4 stapler load. 4 of those 60 is good enough because the mesentery is being taken down by bipolar. So you see the anastomosis is complete literally in no more than about 20-30 minutes. The whole process will be done. And most of our general surgery colleagues will not do any embarkation. I still do this some voodoo stuff, but I don't think it's necessary. So anastomosis is complete, and I think Dr. Alharbi will approve the way the anastomosis has been done. Well vascularized, and also you could use ICG. I mean, if you want to add some cost, the XI allows you to use ICG, which will reassure you of the bowel health. But most of the time, just the way the bowel looks, you could tell that difference. So that's the shear form stapler. I think it adds a lot of value. So these are the things that I'm talking about. Instrument, picking the right instrument. So here's another example of efficiencies. Pick sets of instrument that you like and you're going to be happy with. Don't try out with multiple instruments. You could try out initially, see which one you really like for the work you do, let's say for a bowel work or for a prostate, for kidney. I use always 4 instruments for all of my work. For kidney, for a laparoscopy, for a partial nephrectomy, for reconstruction, and that is progress, bipolar, scissor, and a suture cut needle driver. That's the 4 instruments I need, and I use those 4 instruments for every single case, nothing else. And so what can you get? So bipolar is a good tool because it's a long grasper, it's a great for energy, and it's also good for suturing. So you don't have to use a second set of needle driver. So that's a save of $250 right there. Minimize exchange of suture. So if you use a suture cut needle driver, guess what? You could cut the suture right after you finish suturing. So you don't have to ask for your assistant to put a scissor in there and you have to wait for him. So that saves that time. Of course, some of our colleagues, they use it, but then they accidentally grab it with a crotch and they cut the suture. So you learn how to not do that and you make yourself efficient. And so use 1 needle driver instead of 2. Use the long bipolar grasper for a second needle driver. So that saves you money. So my preference, I already told you, monopolar scissor, long bipolar grasper, progress, and only 1 needle driver, which is a suture cut needle driver. And for bowel reconstruction, you could add bowel grasper, as you saw in that case, but you can eliminate it as you get comfortable. Right now, I don't use a bowel grasper anymore. I use a scissor and I use my needle driver to do my retraction. This is I'm just going to give you a brief because I think I got 2 more minutes. This is a prostate that we have modified, and you have seen this kind of modification. But I'll show you a quick video if we have time, that how this modification led to decrease in time. So, increase understanding of the bladder neck, learn the use of 4th arm, minimize changing of robotic instrument. We talked about that. Robotic time for a radical prostate has been cut down to like 60 minutes. Difficult cases can add only 15 to 20 minutes. And also, if you know the anatomy right, you don't have to do frozen section. Some of my colleagues does frozen section. I say, why? If you know how the anatomy of the prostate, where the capsule is, you're going to preserve that. You don't need to do a frozen section. And it is reproducible because a lot of our colleagues has adjusted to this technique. So what we did is we don't do any more dorsal vein suturing. We don't do staple control of dorsal vein. No need for Foley tucking. You'll see we don't really pull the Foley with the 4th arm. You could actually grab the prostate with the 4th arm, the posterior prostate, and lift it up. No need to take the involucral fascia down. Develop posterolateral plane well. Spare the nerve in a retrograde fashion. Use a single clip. We don't for each pedicle. We don't use multiple clip. And you could peel the nerve from periprosthetic fascia very easily if you're in the right plane. An inversion of the bladder mucosa with a single stitch. And there you go. I want to show you this quick. Those of us does prostate. All right, so this is I'll make it a less than 2 minutes video by forwarding. So this is the bladder neck work. You could see we didn't take the endophilic fascia down. We didn't do anything to the dorsal vein. We just opened the anterior neck and just cut the posterior bladder. And Dr. Vip Patel does this part very well. I actually learned some of his technique and incorporated into this, and long time ago. And here's the seminal vesicle. You could see clearly, and then I'm going to move forward a little bit. So here is the nerve sparing. We already did the posterior work. Here we're getting into periprosthetic plane and sparing the nerve. These getting into this bleeding is good because these are venous and you want to stay behind the venous and lift the vein up. But sometimes these vein wall are thin, they will bleed. So not to worry. So here we'll have a communication going from lateral to medial. And you'll see when we lift it up, I already did the posterior work. And we put the bipolar, again, this is the bipolar grasper. And here, you have one pedicle. I'm just going to thin it out a little bit. And then the assistant will put a clip. We already did the other side. So again, these are the 3 instruments. And the other instrument is the suture cut needle driver. That's all we're going to use in this case. And here we took down the pedicle. And so one pedicle, one clip on each pedicle, you could see on both sides. No other extra clips or anything. And now we'll just take the anteriorly, the dorsal vein complex, and you'll see we're not going to really use any suture. We haven't used any suture. 95% of the time, you could get away without using any suture. Once in a while, you may have a very large dorsal vein. You can put a suture with a V-lock just to control it. So you could do the anastomosis easier. And most of those bleeder, because you're working with pressure of 10 or 12. By the way, one other equipment you should also invest in is something called air seal, which keep the pressure at a constant pressure. So if you set that pressure to 10, it will maintain at 10. Guess what? You don't have to work at pressure of 15 because the pressure of 15 can cause a lot of other side effect in a long case. So if you just set the pressure at 10, you could work at pressure of 10 long as the pressure doesn't go down. And studies have shown that working at pressure of 10 is a lot better than working at pressure of 15. So here we're taking the dorsal vein complex without putting any suture and very clean dissection of the apex, not disturb the, because sometimes if you put a dorsal vein suture, you could bunch up the external sphincter muscle. So I'm just going to fast forward and show you the anastomosis, how we use the, for the anastomosis, we only using the suture cut needle driver. So here, this is a suture cut needle driver, and this is a long bipolar grasper. And we're using this instead of using 2 needle driver. Now, of course, you're not going to do this in your first 20 cases. But as you more and more, you'll get comfortable using the long bipolar grasper instead of using a second set of needle driver. And that's how you save the money. Here, this is a little technique I do. I evert the mucosa, so that way you get a nice mucosal to mucosal anastomosis. So here you could see I'm taking the dorsal vein, anterior dorsal vein with the anastomotic stitch in the anterior. That way it will control that bleeding. Whatever the little oozing that takes place, it's gone. And this is the other side. This is pretty much it. We'll go to the all right. And so what happened is that I was looking at, I asked the robotic, the Da Vinci to give me some stat because they always tell me I'm the most efficient surgeon. I said, show me a slide. So they actually did this slide that they compare my time and the cost with the national. This is the average. So this is the average cost, about $1,600 for a prostate. And the average time, consult time is about 160 minutes. Our time is about 70 minutes. And the cost is about $1,300. So that's like huge difference in the cost with the national average and with the time of the surgery. So the number speaks for itself.
I think we have a few minutes more, Dr.
This is like, we have about 20 surgeons who does prostate. In our institution, you could see I'm right here. So all these little things does make it different in terms of cost and in terms of time. So we all can do this. Implementing some of these aspects will definitely save you time and money. And thank you. And you're all invited here if you ever want to come and observe this thing in firsthand. Thank you so much for having me. I know we're in the middle of the day and we're all rushing to do things.
Thank you very much, Dr. Mutahhar. I'm really enjoying your presentation. You gave, a concise way how to reduce the cost for the robotic surgery for the junior staff and also for the senior staff. Your experience is quite considerable, and I really admire that. Thank you very much.
Thank you, sir.
It is my pleasure to be with you, and I'm sure that I'll be in touch with you again. I think I have no any question from the audience, please. Well, thank you very much, Dr. Mutahar. We'll meet again.
Thank you. I see Dr. Wickland. How are you, sir?
No voice, Dr. Wickland. Please unmute your...
I will. Now, yes. Hi, how are you? I'm good.
How are you, Dr. Wickland? Thank you very much for contributing.
We're across the bridge. We're connecting through Saudi Arabia. That's great.
You are in a different country and connected in a different place. You are welcome, both of you. Dr. Wickland, please start your presentation. I'm sorry, my laptop is freezed. I won't be able to open your CV to present you, so I'm really sorry. So please present yourself and start your lecture.
Yes, thank you so much. I hope you see the image. Is that correct?
Yeah, it is obvious. Yes,
okay.
You can start. Thank you.
So my name is Peter Wickland. I'm a professor here at Mount Sinai in New York, but my background is from Sweden, from Karolinska Institute. I will present some results from the Swedish National Bladder Cancer Registry. I have done robotic surgery for many years, but I'm trained open surgeon, and I've done many hundreds of open cystectomies. So I have done both types. I haven't done so much laparoscopy. I switched almost immediately 2001 from doing open directly into robots because we were lucky that our hospital bought a robot, so I didn't have to struggle so much with laparoscopy. When we started, this is a long time ago. This was when minimal invasive surgery sort of started to be popular in urology, and there were some papers coming out to show that you could actually do laparoscopic prostatectomy. The problem was that the learning curve was very flat and very long. So if you look at this learning curve, it's like 100 cases. This is Dr. Jens Rathweiler. And you see for his 100 first cases, it's almost like a straight line. And then you look at my learning curve. You see, how already after 20 cases, I was almost twice as fast as most laparoscopic surgeons. So for me, one of the major positive things turning into robotic surgery was that the learning was much faster. You don't have to spend a lot of time trying to learn how to suture and these things. So I think, and that was one of the few things that was also shown in scientific studies very early. The thing is, I'm going to talk about cystectomy now, and for cystectomy, it's very important that you have the same guidelines and indications for, as you have in the open, the sort of golden standard open cystectomy. Because in bladder cancer, you know that if you have a positive margin, or if you cannot do the same type of surgery, patient may die very quickly from disease. It's not like prostate cancer where you can allow yourself to have some, leave some prostates without having a major problem for the patient. Here it's like every cell has to come out, otherwise the patient dies from the bladder cancer. You have to be able to do the same type of surgery. This was also discussed a lot about for cystectomy, specifically for lymph node dissection. There was a discussion whether you could do a proper lymph node dissection. And there was also a lot of discussion about various types of urinary diversion at the time. I do think that there are sort of two. So if you think about the actual cystectomy part, this is a short video where you, for me, this is when it became clear that there are some sort of aspects of robotic surgery which is superior to open surgery. And one is, of course, that you have the ability of see the anatomical details. So here we are doing nerve sparing. So when I trained in cystectomy, almost no one discussed nerve sparing and functional sparing. Very few patients at that time underwent neobladder surgery and so on. Here you see that you actually use the robot and you can see the anatomical details. So you can do the part when you do open cystectomy where you're deep down in the pelvis and you don't see a lot. Here instead, you can actually see all the anatomical details, and you see that you all the time have a good understanding, if you know how to do the procedure, where you have the neurovascular bundle, and you can do a very nice nerve sparing. It looks almost like a prostatectomy when you see it like this, but it's in fact a cystectomy with a nerve sparing technique. Okay, I think I'll show you the other part where I think that the cystectomy is, or the robotic cystectomy is maybe superior to open, is the quality of the dissection you can do when you do apical dissection. Many patients, this part is not so important because you're doing conduit, and then it's not so critical how you do this part of the dissection. But here, when you do neobladder, the whole functional outcome will be depending on what you do here at the apex and how you spare your neurovascular bundle. But if you do it like this, you will see that you get excellent results, and the functional outcome for the patient will be great. And you can almost tell them that, you know, there's almost 100% chance that if you can do a surgery like this, that they will be continent daytime. It's a little bit more difficult with nighttime, but you see the quality of the image and the anatomical detail here. The important thing is also that you spare the function. If prostate cancer, you may not do exactly this type of dissection because then you may get into an apical tumor and so on. But for bladder cancer, even if you have, at least in Europe, in Sweden, we have almost 45% prostate cancer in our cystectomy specimen. Here in the US, it's around 35%. I don't think it's the same in the Arabic world, but you want to be sure that you remove the urothelial cancer. Also, this part of the dissection you can do with great sort of anatomic control. Here you want to then remove, without pulling down the catheter that's up in the bladder where you have cancer. So you try to divide here without spilling any tumor cells. So the cystectomy basically is two different parts. One part is the curative part, which is actually taking out the tumor, the bladder and the prostate in men, and the anterior extension in females. The other part is to take out the lymph nodes. There is a part of cystectomy is more functional, and that's the urinary diversion. Unfortunately, it's the part that creates most of the complication. But it's of course not so important for the actual oncological outcome. When you do robotic urinary diversion, it's important that you take into the consideration what we know from open. And what we know is if you want to do a neobladder, is that you should do a spheric neobladder. So you open it and you fold it, so you get this type of neobladder, because that has much better volume pressure relationship. So you can have a large volume without having a high pressure in your conduit or your reservoir. I think that in the beginning, when they started to do robotic surgery, a lot of sort of more unusual and maybe not as good types of diversion were tried. But I do think we should stay with the same principles as we do in open surgery. We are doing a extruded neobladder. I don't have time to go into all the detail. I just want to tell you that what we're doing is very, very similar to open. The only thing is that we do it in a different sequence. So we start by pulling down the intestine to the urethra. So once you have done your cystectomy, your lymph node dissection, you actually take the ileum down and you do an anastomosis here. And once you have your anastomosis, you have everything in a fixed position. Then you staple. And if you want to do extruder, the distal should be only 10 centimeters distal to the anastomosis, whereas the proximal here should be 40 centimeters, because you use this 10, 10, 10, 10 for the actual reservoir, and then you have another 10 centimeters for the chimney. And it's sutured and folded in a very similar fashion as a traditional extruded neobladder, but it's done on the inside. Should look like something like this afterwards, where you have a spheric, this bladder like this, and you also see the chimney, and you have your anastomosis up here with the ureters to the chimney. We have done studies looking at the urodynamic capacity of these types of bladder, and you see that we have a nice around 400 cc capacity in this series. and relatively low pressure. We also have good continence, which means that 0 to 1 pad is basically 100% in this series. Nighttime continence is not as good as, unfortunately, is the case with neobladders, regardless whether you do open or robotic approach. What has been discussed a long time was the oncological outcome after bladder cancer surgery. So I will focus a little bit on that. We didn't see any, so we followed, of course, when we started 2002 to do this, we followed the sort of development, and we never saw that there was a difference. And actually in our cohort, this is the Karolinska cohort, we actually had better oncological outcome when we stratified for stage and grade and so on for the tumor. So we never found this, but this was something that was discussed in the literature, and there were some papers suggesting that there might be difference in the oncological outcome. There are only 2 larger randomized trials out. One is the Memorial Sloan Kettering randomized trial that actually did not show any difference in the recurrence probability. And the other even larger trial is the RAZOR trial that was powered to look at 2-year difference in oncological outcome, and there was basically the same in the both group here. So none of these actually showed the difference, but there has been a discussion about whether there is a difference in recurrence pattern and so on. But really scientifically, there is no difference. This is from the European series where we looked at multi-center from intracorporeal cases in Europe, and they look, the Kaplan-Meier curve here looks very similar to what you find in the open cystectomy series. Functionally, we can also say that the results are good. So you see that the 0 to 1 pad is around 90% in this series. So there are some that don't have perfect outcome, but I think this is the same in open. You will not have results that are better than this if you do open surgery. Nighttime continence is not as great as the daytime continence, but that's also nothing that has to do with the robot. It's more that that there are basically functional problems with the nighttime continence after cystectomy, and that has to do with the neurogenic reflex and so on that are sort of disconnected at the time of cystectomy. Looking at the oncological outcome or the functional outcome, we also looked at the nerve sparing part, and you see that here we have around 80% of the patients, or almost 80%, are potent and can have intercourse with or without phosphodiesterase inhibitors. Also, that is actually a good outcome. You have to remember that the cohort here is a little bit older. I will actually skip this, but this is just to show you that worldwide, in the beginning, many centers, especially in the US, started with extracorporeal diversion, but over time, almost 100% of the centers have switched to intracorporeal, where you do the whole procedure on the inside. And I think that makes much more sense to go intracorporeal. I would also like to present some new data, which is from the Swedish Bladder Cancer Registry. So almost all our bladder cancer patients in Sweden are entered into a registry. You know, Sweden is famous for their sort of meticulous entering of patient data and patient into various types of registries. And we have then combined this bladder cancer registry with the cause of death registry in Sweden. And we looked at all the cystectomies in Sweden from 2011 to 2019. And this is all cystectomy cases, open and robots. And you see that 2,000 were open and 1,000 or less than 1,000 were actually robots. So there is still in Sweden at this time more open cases, but there's a big swing over time here. So when we started, of course, there was no one else doing it. So, but now we are probably pretty much half of the cystectomies in Sweden are done with the robots. There was some difference in the groups here. So the groups are, like you would expect, more male. So it's the same, you know, gender difference here, 25% or so. Age 71, both groups are similar. BMI is similar. ASA score is a little bit higher in the robot group. There was some difference in the clinical stage, so there are some more advanced cases in the open group. There was no difference in the neoadjuvant treatment. There was some difference in hospital volume, so that more cases in the robotic group were actually done on high volume hospitals. So what we did was we did a propensity score matching, which means we matched the two cohorts and we used age, BMI, ASA, prior surgery, clinical T-stage, end-stage, neoadjuvant, hospital volume, and pathological T-stage to have more better cohorts to compare, so that will be more similar. And if you now look, you would see that around 800 or so of the open are actually out of the comparison. So we are now down to 870 to 1,500. And you see that we have the same age, the same BMI, the same, the ASA score actually is almost still different, favoring a higher ASA score in the robotic group. What's more important is that the clinical tumor stage or an end stage are now then similar again, and the hospital volume is also then similar. And there is no difference in the postoperative state, the T stage, so the PT stage is the same. So now we have groups we can start to compare a little bit better. And what's interesting to see is that in Sweden today, there are more neobladders in the robotic cohort than in the open cohort. So there's like 90% of the patients are there should be one M here, but there's 90% are conduits in this group, and 80%, so around 20% neobladders. And Karolinska, where I used to be, then we had around 30%. Here in Mount Sinai, we now have around 40% neobladders. I don't think you should have too many. It depends on a lot of issues and age of patients, patient's preference, and so on, and comorbidity. And lymph nodes dissection, there is a slight difference that actually favors robotic surgery. So we have more nodes dissected in the robotic group here. Blood loss clearly favors robotic surgery. We know that from all minimally invasive surgery that you have less transfusion, less blood loss, and so on, if you do minimally invasive surgery. We interesting also found that there was same. So in Sweden today, the OR time in the robotic and open are the same, basically no difference, despite having more neobladders and larger lymph node dissection in the robotic group. Hospital stay was shorter in the robotic group, so there's a difference in 4-day here. Here in New York, where in the US they are much better in sending patients home and have a better system. So here our median time for robotic cystectomy, they spend 4 days in the hospital, which is like, yeah, for me, very almost impossible to think that you can have a cystectomy home if like the median stay is 4. Used to be when I started open something like this, so it's a huge difference here. The rehospitalization was actually a little bit higher in the robotic group. But when you look at the complication, you can actually see that there is the increase in the complication rate in the robotic group was in the like low-grade complications. But if you look at the high grade, so the Clavien 3, there is actually a higher rate of complications in the open group. So the more severe complications was higher in open cystectomy compared to the robotic cohort in Sweden. So then that's like national wide numbers. And what is also interesting is that if you look at survival, the survival is actually better in Sweden after robotic cystectomy compared to organ. And this is in this match cohort where we should have similar patients going in. I think that is partly cancer-specific survival here. Maybe it's because the robotic cohort is done in hospitals where there are better trained surgeons. But it's interesting that also overall survival. So I do think that there is also maybe other types of mortality. And we know from studies that the robotic cohort, the older and sicker patient you're looking at, the more you benefit from doing a robotic procedure. So I don't think it's strange. It fits well with what we know. I don't think necessarily that the robot is better than open. It's more the surgical skill, because the robot is just a surgical tool, basically. It's no difference. So in conclusion, then, the data from our national register on bladder cancer after propensity matching show that we actually removed more lymph nodes in the robotic group. There were more neobladder formation in the robotic group. There were no difference in the OR time. There was an increase overall in cancer-specific survival after robotic. There was a decrease in high-grade complications, and the length of stay is shorter. But there was actually a higher 90-day rehospitalization rate after robotic cystectomy. So thank you so much for having me on this presentation. I'm happy to stay and take some questions if you have any questions.
Peter, great presentation. Khurshid here from Buffalo.
Hi, Khurshid. How are
As
you?
always, kind of an excellent point of view and very balanced. What do you think the next future thing for bladder cancer in surgical technique would be?
Oh, that's a big, so I don't think that's so. For me, the major sort of possibilities for bladder cancer is oncological treatment in medical oncology. So I do think that this new trend with immune therapy and so on probably is more important than what we are doing as surgeons. I do think that we will also need to learn, who needs the cystectomy in the group that have a non-muscle invasive bladder cancer. We are unfortunately still under-treating bladder cancer because we have a lot of here, especially here in the US, I've found out that a lot of surgeons still do partial cystectomies and things like that. They do bladder sparing, and that's for some patients it's very well to do bladder sparing, but some patients actually die because you do bladder sparing. And to have a better understanding is who you can do the bladder sparing, because we don't have a good way of following patients after bladder sparing, because once the urothelium basically cover the defect that you have done, you don't see a tumor when you do cystoscopy anymore. So if you have a tumor that is sort of breaching the urothelium, you will see it and you'll find it, of course. But many bladder cancer tumors that come back after this type, bladder sparing treatment, they actually come back in the wall, deeper in the wall of the bladder, or even outside the bladder. And when you then see them on scans and so on, they are basically usually too late. So I think that's, we have a lot of developments to do. I'm not so sure about, robotic. It's an interesting concept. We have done maybe like 10 cases or so now or maybe 15, where we have done single port cystectomy, for instance. And I do think it's excellent in females where you do non-organ sparing. You can take everything out through the vagina, you close it, and the patient, you use the same hole for your port and your stoma, so the patient basically, have no holes after surgery. It looks amazing when you see it, but whether it's actually translate to a better outcome, I'm not sure. We haven't really been able to show that.
Thank you very much, Dr. Peter. And any question, Dr. Khurshid?
No. I just wanted to say thank you. It's good to see a lot of people online. It's been a long time. I see Ben waiting in the wings up there and trying to say, hey guys, let me go in. Dimitri, good to see you too. Thank you. Thank you.
Okay.
Yes. Thank you very much, Dr. Peter.
Yes, thank you. Nice seeing you all.
Thank you very much. We will see you again. Thank you. The next speaker is Dr. Ben. Dr. Ben.
Hello, Dr. Alharbi. Can you hear me?
Yes. Can you Dr. Peter, please stop sharing so Dr. Ben can start his presentation. Thank you very much, Dr. Peter.
Great.
Dr. Ben, can you share your screen, please?
Yes, it's just coming. Hopefully that will work.
Coming.
Can you see that?
Yes,
Yep.
it is working.
Okay, good. Well, thank you very much for inviting me. Thank you for the honor of presenting to this meeting, and it would be, of course, nice to be there in person. As good to see my friends of Peter and Vip and Kershid, people I've worked with over the last 10 years who've nurtured me. I'm speaking from London, where for a change it's actually not freezing cold and wet. It's actually pretty good today, which is nice. And I will speak today really about, I've given the title of Pushing the Boundaries of Urological Robotics. And obviously I've taken into consideration the other colleagues' talks. And I think perhaps for me, I'm kind of half kidney, half prostate, and a little bit of reconstruction and things in between. I'm going to focus really on kidney cancer or upper tract retroperitoneal disease. And a little bit on prostate, because I think Peter has very nicely covered a lot of the bladder, and I've seen Vip do a beautiful talk earlier on prostate. So I'm a guys at St. Thomas's. We're very lucky here. We've just because the pandemic has kind of allowed us to use some of this of a political angle to get a few more robots. So we're now we've been going about whatever that is, 18 years with robotics, and we've had 1 and then 2, and then this year we've now suddenly up to 6 because we just bought a CMR as well as having 5 Da Vincis, which is great for the UK. And this is me. I just illustrate the point that everybody has to start with, of course, the basics, and I think that's been said a few times today. That starting with assisting, which is me on my fellowship, they made me wear an Australian hat, and I'm kind of Mr. in love with robots, I suppose, in the UK, and I do, as again, about half prostate, half kidney. And because of this, we've got a sort of multi-specialty which kind of plays into this meeting, I suppose. I've been instrumental in getting going for thoracics, ENT, general surgery, renal transplant, and we're about to get going with pediatrics, and that's in addition to my kind of urology job. So I have this nice role where I can go to different people's operating theatres and make comments about operations I know nothing about, but just on how they do things and how the setup is. And so we have a fellowship here with some people come from all around the world for 3 different periods, 3 different posts, and go around and teach some people as well. So I was just thinking about the concept of pushing forward and to try to do the best you can be in any area. In robotics, what do you need? I think you do need, obviously, some degree of experience. You can't start with the easy cases, and therefore you need a good background in open, in lap probably a bit, and in robotics, and you need volume. You can't get good at something if you're only doing 1 every 3 months. You have to have the volume of cases. Just thinking about, what do I need if I do a really difficult case? Well, I need the anaesthetist I work with every week. I need the assistant. We've got a robotic assistant who's one's done 5 and one's done 3,000 cases. So one of them's got to be there. And I need, ideally a fellow and scrub team that are all team part of the robotic setup. You can illustrate growth for me in partial nephrectomy for the rest of the type of urology and probably the rest of surgery. When we started with robotic partial nephrectomy, the first year we did 10% of the partial nephrectomy. So it's a difficult operation for those of you who don't do it. Obviously risk of chopping a piece out of the kidney and it bleeding. So you took the easy ones, and we're now down to doing 98% of all partial nephrectomies are done robotically. But we didn't go there straight away. It took about 5 or 6 years to evolve. So that comes from having that incremental growth, perhaps a senior person in the department who will mentor you to say, look, I don't think you should do that yet. And we had lots of great discussions at the beginning about whether we should or we shouldn't do certain cases. You need, therefore, supportive colleagues who are going to either allow you to do robotics on their cases. We have this MDM sit-up situation, what I think America would call it a tumor board, where we discuss all our cases, and sometimes we have disagreements, and I have to say, well, I think I can do it. Someone says, I don't think you should do it, and that's difficult. But our referrers trust us, and we keep getting referred in cases. And obviously, you need a bit of dedication and luck. So in prostates, I was just looking at this. I heard VIP say he's done 15 to 16,000. Of course, our entire program over the last 18 years has not done as many prostates as VIP's done on his own. But we've done a lot of cases now, and we do every cases per year. But what do we do now that we wouldn't have done at the beginning? Well, we do a lot of salvage cases. Paul Cathcart, my colleague, is probably the highest volume, certainly in UK, maybe one of the highest volume in Europe, post-focal, post-HIFU, post-radiotherapy, brachytherapies. He's done, getting on 160 now, salvage partials. My special area for the prostates is transplant. We've got a big African and Caribbean population. We've got a big renal center. Therefore get a lot of people who've got bad prostate cancer who've also got a transplant. So we do quite a lot of that. We wouldn't have done that at the beginning. We've had a look at Retzius sparing in that capacity and other capacities. So we're trying some other different stuff. We do the NeuroSafe, which you can see there on the side, as well as the weight of my heaviest ever RAP, which is not as big as my heaviest ever HOLEP, but it's 234 grams is a big old prostate. And of course, men with very narrow pelvis. We've got men from for us, it's from Ghana and Nigeria. Often quite technically difficult when they have bad disease and there's not much space and you've got a big prostate. So that combination can be difficult. So I think we've kind of evolved there. There are lots of cases that we would not have taken on with a robotic prostate at the beginning. And I'm only one part of 4 people really in the prostate team at our place. It's kind of the UK model. But my real joy, I suppose, is doing kidneys. That's been my sort of niche, and looking at how that has sort of grown. This is hopefully you can still see that. It's awful this because you get no feedback whether anyone's even alive watching you. I hope you can still see that. Can anyone see that? Is that video showing?
Yeah, yes, it is okay.
Good. Well, this is a CT down the bottom right of a tumor that was no way I would have tried for the first 400 cases. I would have thought that's impossible, just taking out the whole kidney. And of course, we've seen people, a lot of American, European people doing some crazy cases in conferences, but this is like real world. Would you take on this kind of case? But it's a thin guy, a hilar tumor. We had a good look at it. This is before any real clamping until that point there. We've dissected quite a lot. And it just goes to show that, things that sometimes look much more difficult, look very difficult, aren't necessarily as difficult once you get in there. And I would say that's particularly true for hilar tumors in kidney cancer partial nephrectomy. So we kind of freed it up and then taken this big lump out of the middle of the kidney. And it wasn't, we biopsied it. It wasn't a high grade tumor. So I have a rule, which is kind of our department rule, which is no crazy partials in crazy people. So if you've got someone who's highly morbidly obese with massive previous surgery issues, then that is maybe not a person you're thinking about doing a super difficult partially. But this guy wasn't that situation. So that is just an example of that. So moving on from actual partial nephrectomy, which we started in about 2010. So we did maybe 6 years of just prostates and bladders. And Peter will remember he came over and helped us, and various people at courses and EAU and things. We then got into this a bit more. So we've now said, I'm not doing any laparoscopic surgery at all if there's a robot parked in the side of the room. I mean, why on earth would you? I mean, when you bought the robot, the cost per case are not that much more. So that means now all pyeloplasties, nephroureterectomies, pretty much all radical nephrectomies other than some small non-functioning retroperitoneal ones, adrenals, and the last couple of years getting into RPLND, urethrolysis, and on the left there's probably my craziest single kidney partial that I've done, and we've done about sort of 20 of those now. So then you've used really the technology and the experience of the partial nephrectomy to get into the whole of the rest of this. And we've done so well within this that since I started, I've now got 2 other colleagues who just do upper tract. So I'm like constantly on a fight trying to find all the good cases because Archie, Fernando, and Raj Nair are just doing loads of these. So I suppose that has also sort of built that team feeling around it. Can you do everything? No. These are 5 cases that we didn't do. We did not do robotically over the last couple of years. Now, what would I do now? That I'd probably do the top right. I might have do the top left. I wouldn't have done the TCC in the middle. I don't think I could have done the bottom left, and the bottom right, yeah, also tricky. So, I mean, you know, even now, I showed this slide a couple of years. There's a couple of things there I think maybe we could have done robotically with a few more cases. And caval tumors, I mean, that's kind of like getting into the proper madness stuff there. With you've got obviously the Chinese groups publishing a lot on that, some of the West Coast American groups. You know, I will do level sort of 0, obviously 1, and occasionally some 2s. I'm not someone who got into the 3s and 4s and the cardiac, but it will come. Mainly because my main senior partner here, that's his main thing, cardiac renal tumors. And if I've taken all of his partial nephrectomy, his radical nephrectomy, his urethral lysis, if I take the caval tumors, he's never going to speak to me again. But you can do big people. This is a huge tumor in a guy. And for me, if the human being is quite big, then the tumor can be quite big. What is quite difficult with robotics is a huge tumor in a tiny person, because there's very little room to maneuver. So that was a few year or two ago, a bigger tumor. And then we've got just a few things as we've evolved, and this is kind of hopefully my computer won't be overwhelmed by this, but just to show you a few other sort of niche areas. This is a lateral approach at the top to a retroperitoneal lymph node dissection, and there's the node, and that's how we did it for 2 or 3 years. We used to do a single template of one side. The bottom is one of our first urethral lysis cases that Archie and Fernando and I have done, and she started that. She's done 110 now, urethral lysis. So a lot of these people have one non-functioning kidney, and they're desperate to get off steroids and stent changes, and we've become one of the National Centre for Urethral Lysis. It's a really lovely niche area, very satisfying procedure, and obviously adrenals. So just kind of open the whole thing out. That's me messing about with the cava to see that I've got all the lumbars and that the whole thing's up and that we've got all the right nodes. But there's a sort of little mixture of things. What about huge people? I mean, this guide is not going to go well with open surgery. In the Middle East, I know you have some big people as well. This guy's got a BMI of 70. All of those people around him are anaesthetists, and anaesthetist support team. I was having a coffee, and that's him the day after, or the night after, with a huge tumor. So the robot doesn't get tired, and you can use the technology in different ways. Sometimes I think the really infected benign cases are often some of the most elegant things to do with the robot, because they stop what is otherwise a definite open operation. So the principles of robotics I've got was kind of illustrated by a few nice patients who've trusted me with their stuff. This was at the beginning of COVID, and that was Rebecca in the top left. We've become quite friendly. She brings a baby in to see us in the clinic. So she presented with rather a big tumor in the right kidney and ended up needing a partial nephrectomy, and we got her home within 24 hours because of the whole COVID rules. Her baby couldn't come into hospital, her parents couldn't come into hospital. She's like 22, local London girl. She just sent me a picture of when the baby was 1 year old. And then that is Iris in the bottom left. She's 96. And she had this massive kidney tumor, but was otherwise fine. Why would you do an operation on a 96-year-old? Well, she was fit and well, and she asked us to, and she went home the next day as well. So we've got to do stuff at the highest level. I want to expand the people who can have robotic surgery miles beyond what the group that just had LAP. And I suppose what's really exciting to all of us who do a lot of this is to try and do things that people have never done with robotic surgery or any minimally invasive surgery before. So that's kind of in there as an aim. And there we go. That is Phoenix, and she's 1 year old, which is Phoenix from the flames, sort of a good COVID story. Now these are some other crazy cases we've been looking at recently. So docking the robot to the thigh for a weird SCC of the groin and the scrotal area. So doing a lymph node dissection in the groin. I would never have considered that we could do that a few years ago. Patient did really well, didn't want to have these big flaps. That's a partial next in a bloke with a conduit. ileal conduit and managed to do a partial on the other side. And then top right, we've got a renal transplant patient. So that's putting in the kidney with transplant. We've done a whole load of those now with one of my colleagues. And I go along and help do the ureter, try and help speed them along. And then we've got the transoral surgery team, and they're doing some amazing stuff. So they're, again, they're kind of at the other end. They're just starting, but they're stopping some of these guys having big head and neck operations. This is an interesting thing. I see this is where the whole room would be laughing. This woman looking rather sheepish at the top right is my wife. Now, she's a general surgery, and 5 times we've had someone presenting with gallstones who's also had a kidney tumor found on imaging. And of course, they want the gallstones done as well as the kidney tumor. To do, and I have to just do it. And you can imagine there's some interesting marital dynamics there. So we do a little bit of that as well. What about the adjuncts? What things can we do that will try and help us to do better surgery, to push these boundaries, to do things that are more advanced? Well, there's a couple of things I just want to show you. We work with a company called Innersight, and they are a startup company, and a few of these places around the world, they will, from our PACS system, immediately be able to produce a 3D model within a day. And they'll color it in, they'll mark out the tumor, they'll tell me how deep it is, collecting system, how many arteries, and it's right. It's brilliant. You can use it, you can sit there, that's their website address. You can go on there, you get it, and they can upload off pretty much any PACS system in the world. So we also have Ethicon, have got a visible patient, which is a similar thing that is a bit more sort of more global surgery, not just for urology, and they're looking at a similar thing. I haven't got a vid of theirs, so that's very good. We've also got a situation where Innersight actually made the difference. They did a 3D model, and it was doing quite a difficult partial, and I would never have seen an artery going directly into this mass had it not been for the 3D model. It literally showed me a roadmap that I was unable to appreciate with the CT scan. So it showed me a small artery. Yeah, it would have been, I could have maybe done it. It would have been messier, but again, very elegant if you've got someone actually telling you where it is. So if you then look perhaps at not about expanding skills, and this is something I think would be particularly useful potentially for the Middle East, with everybody, you've got the technology, and you've got lots of programs starting up and getting going, and in the sort of middle of the advancement. Proximie. Now this is run by an amazing plastic surgeon called Nadine Hatchat-Haram, and we have been using this all through COVID with a variety of different indications. But basically their tagline is you can kind of virtually scrub in from anywhere in the world. I'll show you what this means. So this is Jim Porter, and this is one thing that we were trying to do.
You see aortic pulsation? Do you see aorta right around here? Yeah. So your incision is going to be something like this, okay?
So Jim very kindly got up in Seattle in the middle of the night to help us move from that lateral approach I showed you for the RPL&D to a supine approach where we could do a bilateral template. And Archie Fernando and I have started doing these as of last year, only because we were able to connect with Jim on the Proximie. And I use it for the med students, I use it for the residents, I use it for people who want to visit theatre now and they can't come in with all the regulations. But for that, it was a game changer. We suddenly started doing our program in a whole different way. We've done 20 RPL&Ds now because of the Proximie system. So it really has worked, and they wrote it up and it got Archie got it in the paper. It was all quite nice. And of course, that means, therefore, that with building up and striving in this way, this is the port positions for an RPL&D. That's actually a left-sided template on the top right there. It didn't do much on the right side. And you hang up the bow. You suspend it with a series of stitches, a bit like a sliding clip technique where you sort of suspend everything up. So that's taken us from smaller 2, 3, 4 centimeter. These are post-chemo, so this is sticky stuff. And now up to sort of maybe sort of 6 realistically, but if it looks very well defined, 8. So other things that help, I think if you're doing robotics, you do need an ultrasound probe. It's going to really help. You can get BK or Hitachi, so that's going to help your whole program. And they're the two probes. I would not do a partial now without these at least on the side. And if you don't use it on the easy ones, you'll never be able to use it on the difficult ones. So you have to use it a lot to get good at it, how to hold it, look at the Doppler, all the other things. And they've got the different probes there. So I've got one here that you can see some of this. See if this comes. I don't know if it will, but basically it just allowed me in a partial nephrectomy, it's not playing, to see the exact vasculature underneath the tumor. And that's a cyst on the top, on the left there, that everyone was saying, oh, maybe it is or maybe isn't a tumor. And when we did the intraoperative ultrasound, you can see quite clearly it's got a huge solid component. So we use that. I would do that all the time. This I don't do so often, but this is a guy with a single kidney who had a reasonably crazy tumor, and we're using the ICG. So I'll have this again on standby. We'd use this quite a lot. And this is just looking at how you would, I'm showing you a video, of course, where it worked really well. It doesn't always work this well, but we clamp one artery, and basically this shows us that the kidney's taken out, the tumor's taken out, and the rest of the kidney all looks green. So just the area of the tumor is made ischemic. And it was a reasonably big tumor, I think 3.5, 4 centimeters. But we can then, I'm worried about whether it's going to work all the way down to that area. But then when we switch the lights back off the ICG mode, we come back and you can remove this. Now, of course, the ICG tells you what's going on the surface. It doesn't tell you what's going on deep. So you always have a little bit of fear that when you get to the base of the tumor, it's suddenly going to start hosing in a place where you haven't really been able to see it. And of course, it is a bit redder than you would want for a left-sided tumor, but actually it was okay. And then we're just closing it up. So I think the ICG is super useful in that situation. For those of you who don't use this yet, this is a sort of fluorescent dye. It's used on the Firefly mode, and the X and the XI have that as standard. The S doesn't have that. And you get this kind of what they call a pseudo-colored image with a near infrared light spectrum. Final thing I was going to show you with the 3D modeling was a horseshoe kidney. Where is he? Here, which we found, again, I would have been terrified about doing a partial in a horseshoe that was with so many vessels, but I had such a good view of this that, again, I just think it was a game changer. I didn't have to do much dissection. It works well. So do get whoever your local labs are who do this kind of stuff, or use Insight. I'm sure they'll help anyone they're looking for business to do that. So what's coming, what's really going to push us on is, of course, going to be more augmented reality, which is going to be using these digital images and these MRI and CT, and bringing them not just onto an iPad, but actually bringing them into the console and giving a really good overview, as in you get in there, you can see the tumor at the time of starting. And people have got been looking at this for the last 5 or 10 years, but there's no really bespoke system for that yet that I'm aware of that's working well. So in conclusion, I think that when you start robotics in whatever way, that team is important. You build up, you use your experience, because if you have a problem in the first 5 cases, it's very difficult to restart that program. But if you've done 100 and you have a problem, you'll be robust enough to ride it out. So this is an American lady admiral. It says the most dangerous phase is we've always done it this way. And I look for all the legends of robotics around your meeting today, and I'm sure that they have never said we've always done it this way. They're always looking at ways to improve, and I think that's how we grow, and that's how we're going to continue to do the best for our patients. But thank you very much for the invitation, and thank you very much for your time.
Thank you very much, Dr. Ben. It's really a nice presentation. Dr. Guru, any question, please?
Thank you, Ben. It's always a pleasure to see. The question I have for you is this, that when you showed that kidney tumor with around the vessels, and you said a few years back you wouldn't do this, and now you do this, and how the open surgeons would do this and all that. don't you think the field has evolved where you technically are that generation which is saying, hold on, I think I can accomplish a lot. And maybe the next generation which comes in, it doesn't even have those 6 cases which you couldn't do because now their baseline is robotics and they have no open. It's like stone disease. Nobody's doing anatrophic anymore, right?
Yeah. No, you're right. I mean, I mean, I'm not old. I'm 48 yesterday. And I've got 2 colleagues who are 10 years younger than me, and I go, oh, it looks a bit tricky, and they straight away pipe up with, oh, we could do it. And I sort of go, okay, right, well, we better do it then, So yeah, I think having a team environment helps with that. And of course, I work with a guy who's the president of BAUS, Tim O'Brien, and he's 10 years older than me, and he's always been an open surgeon. And so I find it quite challenging, and I don't know whether you have that in your meeting, Kershia, when I say, I think I can do it, and he says, I don't think you should do it. And then it's about who owns that patient, and that mixture between kind of bravado and confidence is something that is a difficult mix. And, when you get young guns who really want to push things early and you think, I know you probably can do that, but if it doesn't go well, that's going to sort of be everyone's going to remember that case. So I think, yes, we are needing to continue to look to do things, but we need to respect the past as well. And if we're not in doubt, or if the patient doesn't want to have it done in the way you suggest, then both people have to agree it's a good operation before you start.
And it's also you have people like Tim around, and a lot of us are blessed to have those people who kind of have had their hands wet and dirty, and they tell you and they try to save you from a problem. And that's a blessing. And like you said, the mantra here is teamwork. And Ben, it always reminds me of I'm sure you know this, his editorial on the Mercedes randomized control trial.
Yeah.
And every time I think of Tim, I think of that editorial. It was so much ahead of time. And a lot of people who were kind of hardcore science guys will say, what is he talking about? The randomized control trial is the only way to go. And then I tell all my students, go and read Tim O'Brien's editorial. It's a 1-page piece, but it's so thoughtful. Anyway, it was a great presentation. Thank you so much for doing that.
Great. Well, thank you. And I look forward to meeting you all in person soon as we can. Get all those vaccines done, and we're going to be able to travel again soon, I hope.
Yes. Thank you.
Thank you very much, Dr. Ben.
I will stop sharing so you can be back on.
We'll move now to Dr. Naif Al-Daham and Dr. Khurshid Guru. Dr. Khurshid Guru is a famous surgeon, and he's the founder and the director of Roswell Park Center of Robotic Surgery, and he's the Attending Surgeon Department of Urology Director. He will be joined by Dr. Naif Al-Daham for a presentation. Please proceed, Dr. Khurshid. Thank you very much for attendance.
Well, I really thank you, Dr. Alharbi, for the invitation. On this meeting, when I was scrolling down, as you know, the Zoom meeting is always difficult and you can't scroll down. I see a name who I have a lot of respect and reverence for. I think that is Professor Ibrahim Al-Orafi. And he is like an elder brother and also a mentor, and it brings tears in my eyes because I'm so in awe of him, and I haven't seen him for ages. So I hope it's him, and I hope he's doing great. Going to this talk, when we were invited to give this talk, I felt that I think I have a lot of gray hair and I'm old enough that I shouldn't be giving the talk for surgery in 2040. So I said, well, who would be the person who would be doing this? So I said, well, I got to find somebody who's the future. And the future is Naif Al-Daham and people like him. So I thought that it would be very appropriate to have one of your colleagues in Saudi who has trained with us and now is a colleague. And so Naif has been a part of almost a lot of these projects. So I requested Naif that if he could take the lead, and I would just do the intro. And then after he's done, him and me can take the questions together. Naif was incredibly good surgical fellow with us in Urong, and then ended up going back to King Fahd Medical City. And I think one of the lessons which and advices Ibrahim gave me was that you got to train our people and you got to train them well. So I'm sticking to my mission, and I think I'll hand it over to Naif, and he'll do the job, and I'll be in the wings if there are any questions. Naif, please go ahead. Thank you.
Thank you.
Thank you, Dr. Guru. I'm grateful to Dr. Mohammed Al-Harbi for this chance to participate in this wonderful symposium. Our talk today, it's about the knives, sticks, mechanical joints, and data, like the journey toward the surgery in 2040. We're going to highlight on some surgical aspects and evolving surgical aspects, and we're going to share together the ideas and that might lead us in the future. So everything in the surgical aspects had been evolved regarding the surgical instruments, like the headlights in 1930. You can see on the left side to explore the surgical anatomy. Then we move to the first Da Vinci robotic arm in 1996, and we end up by laparoscopic instrument and robotic instrument that mimic the human hand. Even the matrix that we were using to evaluate our surgical performance in the past, like the time, like the procedural steps, the accuracy and the precision, had been evolved also. So those nowadays we are concerned about the aptitude of the surgeon and the quality of the end product and the clinical data and the result of our previous surgeries to lead us to take the right decision and to get the right choices, like when to do the surgeon, how to do the surgeon, and who's supposed to do this kind of surgery. And at the end, it might lead us to the automaticity. So even in the animal, the brain tissue is not static, with the experience is going to grow up. In this very nice study, they examine the hippocampus volume in the birds. They compare between the non-experienced and the pre-experienced and experienced birds, how to store the food. And they found the hippocampus, part of the brain had been grown in the experienced bird. Even in the human being, if you choose to drive a taxi, a London taxi, who needs the driver there, they need high navigational skills. While to drive a red bus, I think you're just gonna follow the pre-planned roads. In this study, they found that there was like a redistribution of the gray matter in the hippocampus of the driver for the taxis, which means that the structural brain changes is gonna happen in response to the environmental demands. Miguel et al. Arguing that the brain tissue is not fixed and there is a room of plasticity and it depends on the environmental demand. So the posterior hippocampus of those driver found to be larger than the anterior part. Why? Because in the posterior, the spatial memory, it's gonna be saved. Also, the cognitive function is very important during the surgical steps, especially in the robotic surgery. So in Dr. Guru group, we try to find out the functional capacity of the brain and if it's just gonna change with time. So the first IRB for that study, it was submitted in 2013. That study, we were like using the EEG mind mapping, utilizing 120 lead during the surgical steps, especially in the prostatectomy. And we found, we compared between the trainee and the expert. And we found if you ask the trainee to do basic skills, you will find the mental workload and the cognitive load between the expert and the trainee, it's almost the same. But if you advance and you ask them to do advanced skills like the anastomosis, the urethro, physical anastomosis or lymph node dissection, you will find that the mental workload and the cognitive workload also is going to be higher at the trainee than the expert, which means that during a critical steps, you need many areas in your brain to act together
like in the lysis of the adhesion, just like a few areas that's going to be connected in the brain, while in the lymph node dissection, which is more critical, a lot of demand in the mental demand and cognitive. So a lot of areas going to be connected with each other. The 3 rules of the robot. The first rule, that the robot might not injure the human being. The second one, that the robot is going to obey the command of the human being. The third rule of the robot, that the robot is going to protect its own existence as long as the protection will not conflict with the first or the second law. Just imagine that was supposed to be in 2058, and I think we are almost there. So we study more at Atlas Lab with Dr. Guru group about the brain function during the surgery. So we monitor the mentor-trainee trust during the robot-assisted surgery. We found that the trust and the concerning, it's going to be different according to the steps of the surgery. Like here, when we have the urethrophysical anastomosis, the trust, there was some sort of a trust and a little bit of the concerning. So the gap between them is a little bit not that far. While if we go to the lymph node dissection, we will find the concerning of the mentor, it is more and more, while the trust is less. So again, even the mentor, when you're watching his trainee, we found that a lot of brain area is going to be acting and reacting together during critical steps like the lymph node dissection, while it is just a few areas in the brain that are acting during a regular steps like urethrophysical anastomosis, while in these steps you just need the muscle memory rather than to interact with the brain areas. In the same study, we used the eye tracking, also EEG, to see what happened to the surgeon during the critical steps of the surgery, like the bleeding. We examined the saccade and the the fixation rate, and we found that the surgeon during the bleeding, they have lower saccades and higher fixation rate, which means that they more concentration and engaged in the surgery. Again, in this picture, nice picture, you will see a lot of area of the brain is going to interact with each other during the bleeding, while in the normal situation, you just a few area that interacting. Again, here it's a reconstructed images, like this is before the step of a bleeding, that the brain is just acting normally and with the low demand, while here during the critical steps, we found most of the brain is busy and interacting with the areas, interacting with each other, more at the occipital area, and what we think that this is the area of coordination and analyzing of the information. As a teacher and trainee, we should know and understand the Dunning-Kruger effect. So if we learn a new surgical steps, we will think in the beginning there is no difficulty, so we will take it easy and our confidence is going to grow up until we reach to the point which is our ego is going to affect and we will become incompetent. But with the experience, we're gaining the experience, our confidence is going to go down until we reach to the point of the plateau when we became like an expert. Now, I'm going to move to another very interesting area, which is the artificial intelligence and its application in the clinical practice. The machine learning, the definition of this, it's a process that learns how to generate a better outcome while running. So to understand this, we need to just define some terms. The artificial intelligence, just if you have any algorithm that mimic the human intelligence. While the machine learning, if you add for this algorithm a lot of statistical methods and models, it's going to improve the performance with time and with experience. Until you reach to the deep neural network or the deep learning, when you have this system, automatically it's going to update itself and correct the mistakes. Simply, this process is going to act like the brain, the human being brain, with let's consider this is like in the neurons, and those connection is like the axons. So those neurons, it's like the computational units. We have multi-layer. Some of those layers, it's hidden to analyze and coordinate. And at the end, we will have the output level to get the information. The life examples of the artificial intelligence started in 1996 with the IBM when the world champion by careful hand programming. It was heuristic is rough guess when actual information is not available, but with the crafting, heuristic in engine programming was how you taught the chess before machine is learning. Here is another study. It's comparing the AlphaZero AI with its competitor. So the AlphaZero machine is just giving no human input, while in the competitors, they work out by playing itself over and over, and the AlphaZero win the 100 game out of 100. Now coming to the application of the AI in the clinical practice. This is a study published in the Gastroenterology Journal in 2018 to identify the polyps and the number and the sizes in real-time colonoscopy. They compare it with the regular gastroenterologist and expert, and this is the arm of the AI. They found that the central neural network can identify 45 of the polyps, while the expert identified 36, and the regular gastroenterologist identified 28. This is another study in the same idea. They found the artificial intelligence has the potential to provide the automated detection of the colorectal polyps. Dr. Guru Group in 2019 published a study about utilizing the computer vision technique with the artificial intelligence to assess the surgical performance of the lymph node dissection after robotic prostatectomy or radical cystectomy. The information taken from the console feed videos, and when we initiate the algorithm and the deep neural network was able to convert the real image to binary grayscale and the binary, black and white area. And this area is identified by the computer. So according to the organization and discrete organization of the image, it's gonna indicate the clearance of this area or not, so we can judge if it's this lymph node dissection done properly or not. Another application of artificial intelligence in clinical practice to identify the lymph node metastasis in the breast cancer. In this study, they challenged 11 pathologists, expert pathologists to identify lymph node metastasis, and they found that the artificial intelligence achieved better diagnostic performance and also in the less time. Here again, another study to find out what about artificial intelligence in diagnosis and grading the prostate cancer. This study, they used the Cohen-Kappa for each pathologist, and they asked the pathologists also among themselves to compare between their readings, and also they did external validation for this. Then they compare it with the artificial intelligence to identify the cancer and grade it, and they found the accuracy, the sensitivity, of detection of cancer was 99%. Here also, Dr. Guru Group, we utilize again the EEG from the eye tracking for the patient after prostatectomy and cystectomy. We let those patients after the surgery in the day one to go to the art museum, and by recording the EEG from the eyes, we try to identify their mental well-being and the anxiety and the hope. We validate it with the questionnaires. Then we initiate the algorithm to find out if the artificial intelligence can identify the mood of the patient depending on their EEG readings. And we found that 94 to 95% the accuracy of this algorithm. So who knows, in the future, with maybe the psychiatrists are gonna give their patients those cabs to monitor their modes just over 24 hours, like the Holly monitor for the heartbeats. In the future, we will have the the nano robot that it might be utilized also for, like in the surgery, for high precision surgeries. in detoxifications of some toxins, and also in isolating the cancer cells. We know that the mind-controlled gear shifting for the future bicycles, it's gonna be there for the robot. And we know that the small animal like the cephalopods, that they have RNA editing around 130,000 editing, while in the human being, only 3% of the human gene are edited. So, and we know that the RNA, rather than the DNA edits, it might lead to evolving of complex and extraordinary behavior. Thank you so much, and the floor is open for questions.
Excellent presentation, Naif, and very well orchestrated. So I don't know if anybody has questions. I think we'll wait for the faculty if there's anybody who has any comments, questions, and
any question from the audience?
It's a very interesting article, or very interesting topic. How can we apply it to decrease the learning curve for the trainee or for the surgeon himself? What is the applied method for this subject?
do you want to take it, Naif, or should I take it?
Oh, you can go, sir.
Thank you. So absolutely, I think what you have to do is all these platforms are evolving, and this EEG platform is, I think, ultimately the final frontier for training. Now, why do I say that? When you teach somebody to sit in a simulator, and I did work for about a decade on surgical simulators, and you teach somebody to sit in a simulator, and you can take a school kid who plays video games and make them sit in a simulator, and within a month, they're as good or better than us. The problem is, after about 5 years, I realized that it is not the technical hand gesture skill or the muscle memory which is important. It is the mind and the decision making. So I kind of started this IRB, which was very hard to approve, where I put a 120 lead EEG on my head and operated for about 5 years. And this data evolved. So what's going to happen in the future? That's why we said 2040, is that you will wear a cap like this, go to sleep or operate. It will kind of navigate you, guide you, and also tell you if you're in a state to do this. And same thing with your patients. They'll go home for pre-op, they'll wear a cap, they will send the data to their psychiatrist, their mental well-being. They'll send data to you with questions. It'll be synced at a much higher level. That's kind of, if you see, our focus is more of a neurologic / mental work, and kind of more of mixing computational things. So we're not, our lab is more not innovation lab rather than an application lab. So application lab means Intuitive Surgicals came out with a technique and we are following it and seeing, does it work? No, we are a complete new innovation lab. So what the answer simply to your question is that few of these techniques probably are in the pipelines for the next 5 years. Right now, what we have is what you're doing right now, sitting in the simulator and increasing your muscle memory. And with time, what happens is your brain adapts like Peter Wickland's or Ben Chelcom's, and slowly you evolve to a point where you can do these surgeries because your mind has evolved like that cab driver who basically processes this way better. And that's, I think, what happens. I hope that kind of explains the answer a little better.
Thank you.
Doctor, I have a question, Dr. Khurshid. I think that the artificial intelligence now is the main issue for investment and research, in especially United States. We have a meeting, a symposium in a few months about artificial intelligence. But my question, what do you think the subspecialties that who are going to get benefits from artificial intelligence other than urology?
Well, you saw it will be imaging, it will be pathology, it will be surgery. I think everything is going to change. The field, I think in 2040 will look very different than when you and I have been practicing. What's going to happen is that you'll have people join medical school, they'll get an EEG cap, they will within a year know they're going to be surgeons or not. And people who will become surgeons will be way more evolved, different than, so you will know not by practice that do you have the skills, but by your mental performance that are you going to be the skilled surgeon or not. And if you are not skilled, you will have more of at a higher level intervention by partnership and by computers, which will take all the information from all the global surgeons in the world and help you align in that direction. I think the world is going to be a very different place. What you see with, for example, Intuitive and these robots is technology from 80s. It's mechanical joints run by a computer. It has to evolve further than that, where decision making is more AI, where you are taking 50,000 brains together and putting them together and making a decision. It's way more evolved and at a very different level, I think, boss.
Do you think, Dr. Khurshid, that the cost, we are still struggling with the cost of robotics, especially in developing countries. Do you think the world is ready for the next move of AI, and it's more, of course, it should be more expensive?
So, it's same thing when somebody probably told IBM that 40 years back, there was one IBM computer in a city and everybody felt. So the difference here will be this, that the companies like Intuitive and people who kind of do mechanical joint work, it'll become like a throwaway gadget. More will be more cerebral controlled stuff, AI decision making, and it will need probably one headquarter in a country, which basically will direct a lot of this. So it'll be more national investments at a bigger level. Now, this is my lab and my vision for the last decade. I say this to people all the time that there will be a day when we will sit back, feed the patient's CT scan or MRI and the labs and the pathology, and it'll come back and say, this is the procedure we want to do. And let's say partial gastrectomy or a breast excision of a mass, it'll say, we don't believe it should get an excision. We think we should get chemo first or hormone therapy first. And once it reaches this size, we advise excision, we advise the approach, which is axilla, not front, because we feel data shows this. And then you will approve that. And the moment you approve it, you put the patient on, put the ports on, it'll do the whole surgery, and you'll just have to approve it like a radiologist.
My personal view that I have to be careful, otherwise some surgeons, they will lose their job in the future.
Well, it's like evolution, it's surgical evolution. Like Naif was showing that when they used the headlight at Harvard in the OR, everybody thought that was the most technology could do. But technology is going to take over a lot of decision making on you and me. Think of this. If it was just me in the OR or you in the OR or any of the experts on the panel here operating versus all of us together operating.
Yes.
It has to evolve. There is no other option.
Well, anyhow, thank you very much for this presentation. I'm sure I'll be back to you because as I told you, we have a meeting in a few months about AI in Saudi Arabia. I guess you are over time in this AI, so you are welcome to join us again. I'm really glad
I would love to join, and you have Naif there too. You could put him to work.
Absolutely, you and Naif. Why not? Yes.
No, it's nice to see you, boss.
All right, and if anybody else has a question or a comment, we would really appreciate it. It's always good to see a good panel and hear from people.
I can see Dr. Aliyin from US. Any question?
Yes, no, that was excellent.
Welcome.
Thank you so much.
Surgery,
Thank
for
you
sure.
so much.
Okay, I think we'll move to the next speaker.
Thank you so much. Take care.
Thank you very much. Thank you.
Thank you.
It's Dr. Dimitri Pushkar from Russia. He's the professor of urology, a chairman of the Department of Urology in Moscow, a fellow of European Board of Urology, and he's the chairman of the Department of Urology. How are you, Dr. Dimitri?
Very nice. Hi, Dr.
Nice
Alharbi. Thank you very much to invite me to participate in such a meeting. And what I did, just to avoid any technical problems here from a different part of the world, I just sent the presentation. So you go ahead and just start this. It'll be like pre-recorded presentation, which I sent to Dr. Alharbi yesterday.
Yes, I will start.
Dr. Alharbi, can I say something before you start? I suppose you left the best to the end, and you let us smaller guys go ahead of Dr. Pushkar.
Come on, stop it, Guru. Stop it, okay? Okay.
Please go ahead. Thank
you. I appreciate it. Thank you.
So do you like me to start your video?
Yes, please.
If there is any, because we had this afternoon some difficulty in the audio, so if there is a problem with the voice, please let me know to stop, then you can do the presentation your own way. I will start.
Shouldn't be any problem, okay?
Okay.
First of all, it's a pleasure to be united with this particular talk of robotic urology. My task is to orient those who are dealing with robotic urology, let's say, patients from outside, just as you construction itself. And just training colleges in the national surgery exposure. So
is the sound sounds good, Dr. Dimitri? Please unmute, Dr. Dimitri. Unmute, please.
Yes, absolutely. Let me just voice it over, okay?
Okay. So we will
start from the beginning. I just mute myself over there, and I will just voice it over, okay?
Okay.
Sorry about that.
It's okay. You can try at your side playing the video again. Maybe
I can do it from my side.
Yeah, try again, please. If you have a problem in the audio,
it's only you can do it. I can share the screen with my presentation, but my video wouldn't play because it's a very heavy videos. That's why I decided to send it to you.
Okay, please start your presentation without the video.
No, you start my presentation. I'll voice it over.
Okay.
You just mute me there, okay?
Okay.
And I will voice it over. Is it possible for you?
I'll try, yes.
Okay, I appreciate it. Thank you. Sorry about that. So just voice, just mute me, okay?
Yes, is it working?
Yes.
Go ahead.
Yes. Great. So basically, female robotic urology. I was asked to cover female robotic urology and pelvic reconstruction. And I have just my disclosure. I don't have any just a keen interest in robotic surgery and stuff. And basically, I do believe that I will try to orient you in anatomy and probably the possibilities to divide this talk to routine and establish as a sacrocolpopexy, which is probably well known for for many of yours, and neurotechnologists such as ureteric reimplantation, distal ureteric reimplantation, and all these patient expectations, because we're basically talking about iatrogenic traumas, unfortunately. And the simple question is, do we have some sort of robust data in order to, let's say, cover this in details? And I can tell you that you move my slides?
Yes, it is moving. Yes.
It's moving. Okay, great. Because yeah, it's not for me. No, it's kind of you know what? Let's try to do it from my. Sorry about that, guys. Let me share my screen, okay?
Okay.
Mohammed, let me share my screen, okay? Maybe I can do it.
Okay.
Sorry about that.
Dr. Dimitri, is it okay for you to start in 20 minutes because Dr. Eliane was going for surgery?
Alian, look, you go ahead, and I have to go. So basically, I'm really sorry of these technical problems because I have sent this presentation a couple of days ago. So basically, I wouldn't be available later, and I'm extremely sorry for this.
No, it's okay. So it's okay.
No, I'm sorry. Look, I'll try to do my best now, but I'm not sure if I can do it. I mean, I don't know. I don't know why, because you know, I thought you just received this in perfectly shape, you know, this presentation of.
Dr. Eliane, you will be back in 20 minutes.
I can be back. My surgery is going to be about an hour. I can work it out, or I could do it tomorrow for you.
Okay, I can do it tomorrow for you also, you know. I can do it tomorrow for you also. That's probably the best way.
So we'll continue with you, Dr. Dimitri, and Dr. Eliane will be back in half an hour. Is that fine?
Let me try. What I'll do is that I'll have somebody text you from the operating room.
Okay.
Because my patient is being put under right now.
Thank you very much. Thank you.
Sure. If not, then we can schedule. Thank you.
Thank you. Go ahead, Dr. Dimitri. Go ahead.
Sorry about that.
Okay.
Can you see me?
Yes, go ahead.
Okay. Can you hear me well now?
Yes, the sound is good.
So thanks again. Sorry about that. So basically, I want to just orient you in a female urology concerning not only routine and established procedures such as sacrocolpopexy, which is probably of less interest, rather than in neurotechnologies and ureteric reimplantations, and just give you anatomy of these kind of a tricky cases. And I enjoy those presentations from all over the world today. There's fantastic course and fantastic change of ideas, I would say. So basically, yeah, robotic surgery, female robotic surgery is not experiment anymore. So this is very important thing because we should understand there's several dozen articles concerning both routine and established procedure and concerning technical things along with the future line. So basically, if we go to ureteral reimplantation robotically, unfortunately, we don't have find so many articles, and they're getting more and more. Concerning patient position, that would be the same as the radical prostatectomy. And I don't think that you'll find a difference, especially with an XI machine. We published several articles concerning lap ureteric reconstruction. And I don't know if you have those guys and female patients, and in your countries, we're receiving them from all over the world. Just to get you inside, we do have some tools to find the ureter. We do have some neon double J stands. For example, doing hysterectomy, we may find and orient ourselves to find those ureters, as the majority of patients with ureteric trauma in a distal part would be post-hysterectomy in a sophisticated world, rather than probably bilateral obstruction or bilateral injuries within a labor when we're talking about African cases. So really think them both. And again, we were talking about ICG today. ICG also could be successfully used, inserted directly in the ureter or intravenously to see if fibrosed ureter is necessary.
Excuse me, please share your presentation, because it doesn't show here.
Why that?
I think it's not launched. It's showing the file.
It's sharing, yeah.
Okay, go ahead. Thank you.
Absolutely. Yeah, it's sharing. I can see you, and I can see the presentation.
Okay.
Can you see, guys? I mean, somebody with us?
Oh yes, I can see, but not sure that it is the right presentation that you are going to present.
That's exactly what you asked for. You asked me to present distal ureteric, robotic.
Yeah.
So basically, for the fibrosed ureter or transected ureter.
Yes.
And for example, these, if we're talking about the ICG ureterally, so you may see these very fine and basically fine ureter. So this is the courtesy of Professor June, and with a triplicate ureters. And that's unfortunately, my videos that wouldn't be playing perfectly, because that's why I decided to send them to you, Mohammed, because they're very heavy. But you know, and unfortunately, you did get the presentation well. Look, maybe I just send you the presentation today again, and you go through this, and we will make it tomorrow. Because otherwise, that will be the screwed presentation. I don't want it, because it's such an honor for me to participate in this. Yeah. What do you think?
It's up to you. I can do it again tomorrow for you, or you send me the PowerPoint presentation.
That's what we did yesterday, and everything went well. Yeah. Unfortunately, the sound is not okay there.
Yeah.
Maybe we can do it tomorrow.
That's fine, but you will send the video again, because I have it already. But you will send the PowerPoint presentation or the video?
No, I will send the same thing, but the sound will be the good quality.
Okay, we'll try again. So
let's do it again tomorrow. I'm sorry about the guys. It was really happy to see you all. Okay, appreciate it.
Thank you very much. Thank you.
Sorry about that.
That's okay. Thank you very much. We will back in 1 hour time. Dr. Eileen will start in 1 hour time. She has surgery right now. We are sorry for this disturbance in the audio visual, but hopefully we can overcome this problem.
10 دقائق بس. ما شاء الله. لا لا بس قاعد على راسي علشان تتمشي. إن شاء الله. بس قصدك يعني لا يكون.
والله شيل مع الحامل والسلطات ولا الشيش طاووق يسخن. اما هذا بنحفظه خلاص، هذا شيلوه بالثلاجه بكره. اي بعد اخويا حتى لو كنا نجيب لك جديد مو بس دعوه. ايش دعوه هذا؟ يكون معنا بكره.
إيه خلاص انا يعني دبرت اللود فيجوال من الشركه خلاص. واونلاين نفس الكوريه بالتعاون مع ايه بالتعاون مع الروبوتيك هذول.
تغدوا ولا خلينا معك؟ لا بروح نعزم الشيخ في المطعم.
لا والله برتاح
ما قصر.
والله امورهم طيبه، واحد منهم زعل طبعا عشان
روسي
ايه
الروسيين تسلهم قطر عندنا قالوا يزعلوا بس.
ايه لا بس يعني بروفيسور مو بسهل. خلاص
موجودين يسوون ساعة.
لا خلصنا 7:30 اعلنا للناس.
ايه مشكلتكم الناس يبون ساعة.
لا بس الألف يا دكتور هذه علامة طيبة ترى. يعني معناته إذا تحط
هم عن قريب من الألف ترى هم نشرنا احنا نشر دور.
بس خلاص هي تنشر نفسها. إذا قلت فري إنه عرفنا الشركة حتى لو بيحجونا يقولون هذه له 30 ولا 50 ولا كذا نقول لا يا أخي في 1000 بس إحنا علشان الظرف الطارئ. والسنة الجاية لها.
لا نقول لهم على اليوتيوب مش في الزوم الألف. هم على اليوتيوب
ما يدرون.
لا ما يدرون بس خلاص. ما اتوقع ما يدري الشيء هذا تعال شيل هذا، خلي هذا هنا.
انا برا
بكره بعد. خلاص نركب هذا